Good morning, everyone. Thank you so much for joining our quarterly education series, which is sponsored by the NICER Consortium. Today, we have an exciting group of talks on macrophage activation syndrome. My name is Chris Failing. I'm a pediatric rheumatologist at Sanford Health and the University of North Dakota. I had the pleasure of moderating the session today with Dr. Jamie Lautfy, a hematologist from Phoenix Children's. Our first session today is going to be Dr. Andrew Grimm, and the title of his talk is Approach to Prolonged Fever. This will be followed by our second talk by Dr. Scott Canna. We'll be discussing biomarkers in macrophage activation syndrome. We'll then have a 15-minute break before we transition to our last talk from Dr. Grant Schulert, who will be presenting management of macrophage activation syndrome and current therapies. We'll then have one final 15-minute break before we transition to our live fireside chat, which is a live question and answer session with today's speakers. I would now like to introduce our first speaker, Dr. Andrew Grimm. Dr. Grimm is an assistant professor in pediatric rheumatology at the University of Michigan. He attended medical school at the University of Illinois, Rockford campus. During this time, he commissioned into the U.S. Navy. He completed his pediatric residency at the Naval Medical Center in San Diego. He then served as a naval officer in general pediatrics in Japan and San Diego before attending the University of Michigan for his pediatric rheumatology fellowship. The title of this talk today is Approach to Prolonged Fever. And I'll pass this over to Dr. Grimm.
Good morning. My name is Andrew Grimm. I'm a pediatric rheumatologist at the University of Michigan. And this morning, I'd like to talk to you about the approach to children with prolonged fevers. No financial disclosures, but I would like to say that as a pediatric rheumatologist, my approach is affected by my specialty. So if a infectious disease doctor or an oncologist is giving you this talk, it might look a little bit different. I have a few goals that I hope that you'll see through this lecture, and big takeaway points are written here. First, I'd like you to really appreciate the importance of the history and physical to guide your approach to prolonged fevers. Secondly, I'd like you to be able to develop a framework for how you might think about prolonged fevers in children. And I really like this quote from Albert Einstein on education. It is a paraphrase. He says that education is not the learning of facts, but the training of the mind to think. And so that's a good bit of the theme of this talk, is that I want you to think more than memorize. And so while I'll be presenting some details, it's more the approach that I want you to take away from this. I'll start with an illustrative case. So we have a 19-month-old girl. She's unimmunized, but otherwise she's healthy. She has 6 days of fever that gets up to 104 Fahrenheit. And this fever started about a week after a runny nose developed. She has developed a rash in concurrence with the fever. It's been persistently there, but it does wax and wane in intensity with the fever. And of note, her fever is responsive to antipyretics. And when she does respond, she goes back to nearly her normal, not quite, but nearly. She does have some decrease in appetite and energy. There's really no other focal findings, and her mom is unsure if her joints hurt her or not. I just wanted to highlight a few elements that I think are important things to pull from this initial history. While it's not an extensive history, within a few lines, you can get a good bit of information. And so she presents to the ED on day 6 for her first evaluation of this illness. She has this rash. This is not her. This is a representative rash. And so your goal is now to figure out what's going on. But before we go any further with this case, it's now time to talk about how we might approach someone like her or someone presenting with a prolonged episode of fevers. To get us all on the same page, let's first talk about some definitions. What is a prolonged fever? Up for debate. There's no exact definition. Might say it's longer than 5 days. Some might say it's longer than a week. It's up for debate amongst experts as well as lay people. What about a fever of unknown origin? So also not quite set in stone, but a general definition is that it's a fever greater than 38 degrees Celsius for at least 8 days, despite getting appropriate initial evaluation, whether that's ED, pediatrician, or in the hospital. And then something we won't spend too much time talking about today is recurrent and periodic fevers. But just to give the definition there, it's 3 or more episodes of an unexplained fever in a 6-month period, so half a year, that occur at least 7 days apart. So not a fever and then a day later, another fever, or 2 days later. They may have a strict periodicity to them, like every 28 days, or be variable time between episodes. So some may be like a month apart or 2 months apart. So the approach to fevers, first, it helps to know what you're looking for. I only throw this slide in here, or this image, not for you to read it, but for you to just look and see the myriad of possibilities for fever of unknown origin that Up to Date would like you to think of in a child. This is not a comprehensive list of reasons for prolonged fevers. If you look through it, you'll see that there are some that are missing. But it's a lot of different things. And it's hard to know everything. It's hard to remember everything. I don't think you need to know everything and remember everything, but you need to have a framework that can help you uncover what's causing the symptoms in the child. So nothing groundbreaking here. The diagnostic approach involves history, exam, and testing. This is pretty much the same with every aspect of medicine. But for the history, you need to know how to ask the right questions, or what questions are the right ones to ask. You need to know what to look for on the exam, and you need to know the right tests. And I really believe that the right tests follow from the history and exam. For the history, I've broken it down into 5 aspects that I like to focus on for prolonged fevers, and really for most diseases or disease presentations that I evaluate. I'm going to go through each of these different aspects of the history. I just warn you, things are not comprehensive. It's again to give you that overview, to give you my thought process, which can maybe help inform your thought process. So first off, the duration and periodicity. Is it truly prolonged? Is this a fever that's been going on for 5 days, for 6 days, for 7 days? Or did the child have a fever for 3 days, then they had 2 days off, then they had a fever for 2 days? Is that back-to-back viral illnesses? Or is it truly prolonged where there's been no gaps in the fever presentation? Is it a true fever? How are they taking it? Is it temporal temperature? Is it under the tongue? Is it an infrared temperature sensor? What do they call a fever? Is this somebody who's calling a 99 point something a fever? Or is it truly 100.4 or above, or 101 and above? So trying to decipher that can be sometimes tricky because parents may not take the temperature all the time, and they rely on palpation to assess the fever. And timing of the fever, I think this is quite important. So here we have a graph of fever in a child. You can see the spikes there. Spikes are happening once a day. This is a quotidian pattern, meaning once a day. And this is the classic typical pattern for Still's disease or systemic JIA. It doesn't have to be quotidian for Still's disease. It could be double quotidian. It could be somewhat random or chaotic. But if you're answering a test question, it's going to be quotidian. And in real practice, a quotidian pattern should really raise your suspicion for Still's disease. There's another very well-known type of pattern fever. So this is malaria. I'll pause to see if you would get it. So I think whenever we're thinking of patterned fevers, the 2 most common things that come up are Still's disease and malaria. But then the fever may not really be that patterned. It may be unremitting, in which case there's many things to think about. For this talk, I've just highlighted a few. So Kawasaki disease is a classic unremitting fever in childhood. MIS-C as well, though I'm not sure how much we're seeing anymore of that. MAS and HLH, macrophage activation syndrome, hemophagocytic lymphohistiocytosis, or unremitting fever syndromes. More on that coming in the next lectures. Bacterial infection, such as TB or bacterial sepsis, those could give you prolonged fevers that are really persistent as well. And then going back to that periodicity recurrence, this is not for you to necessarily memorize or a big component of the talk. I just wanted to show how the duration of fever can really be useful when you're evaluating kids with fevers. These are periodic fever syndromes, and then the length of time is days on the top. And these are our most kind of famous or well-known periodic fever syndromes. And you can see that they each have a distinct amount of time that a child can have a fever for. So really delving into that history, getting as much accurate detail as you can from the families, or requesting it if you're not getting it initially to have them keep a fever diary is extremely important and can really guide you down the right path. After the duration and periodicity of fevers, the next aspect would be associated symptoms. So this is that wonderful review systems that we all use. But you need to remember, you have to ask it. If you don't ask it, there's a good chance they may not tell you. They may not think it's related. They may not think it's relevant. A kid who fell, landed on his hip, he may think that the pain in his hip is really because he fell and it has nothing to do with his fever. But he may have fallen because he was having some pain and weakness in the hip because of infectious osteomyelitis that then got worse after he fell. So they may withhold that not because it's trying to, but just because they don't think it's actually relevant to what you need to know. That's a little bit of a drastic example, I'll admit that. But a complete review system is really necessary. The 14-point of review systems we all say we do in our notes. As preparing for this lecture, I looked at the 14-point review of systems, and I'll be honest, I never do the full 14-point review of systems, but as comprehensive as you can is really useful in these situations. And then not all symptoms need to be present at the time of evaluation or the time you're seeing the child. This is a classic chart for Kawasaki disease. I'm sure many of you recognize it. I just want to highlight that fever at the very top. You can see the duration of that fever. And if you look down at the bottom three, the mucosal changes, conjunctival changes, cervical adenitis, there's a good chance that those may have come and gone by the time you see a child and they're still having a persistent fever. So really it's something you need to focus on is all of the symptoms they've had pre-fever, during the fever, while you're seeing them to get the full clinical picture. To the next aspect, the past medical history, quite crucial as well. Sometimes it really gives you clues, sometimes not so much. Is the child immunocompromised because of something we're doing to them, giving them medications that suppress their immune system, or due to an underlying immune deficiency or immune dysregulation? Are they set up for unusual infections? So an immunocompromised child is, of course, going to be more susceptible to the infections that the rest of us can encounter, not develop. So fungal infections, mycobacterial infections, things like that, that can be slow, indolent, persistent. Or is there a complication of their underlying disease that is now showing itself? This slide here represents the bone marrow pathology of HLH or MAS, macrophage activation syndrome, which is more common in a condition like Still's disease, or there's familial forms, primary HLH, or you can get secondary HLH secondary to a cancer diagnosis, secondary to an infection like Epstein-Barr virus. And so for those kids who are immunocompromised, is their disease something that can lead to HLH? Something to consider when you see somebody with a persistent fever. And then have they had similar episodes in the past? Is this a clue? Is this the same thing that's happening again? Is it the exact same? That's definitely a good clue. Or is it a red herring? Did they have a strep infection a couple weeks ago or a month ago? And that may have taken some time for them to get in, get diagnosed, get treatment. And so now they have another symptom of fever and they're like, well, it must be the same. They had the similar symptoms before, but actually there's something different about it. And we're not asking our patients to be medical experts. So we're the ones who have to kind of decipher the similarities and differences between past episodes and the current episode. The next aspect would be exposures and triggers. I've divided this into three different exposure trigger modalities, though there's invariably many more. The things that might trigger an infectious process, an iatrogenic process, or for lack of better terminology, immune triggering process. So first, infectious. The plane, I think you all know, is going to represent travel. So good travel history is always critical in a prolonged fever. We do rely on our infectious disease experts to get this, but everybody should be focusing on the exposure through travel. And so is this the patient who's traveled, or is it a relative who's traveled? So we think of the kid, but maybe grandparents are visiting from a TB endemic area, and you miss that because all you ask about is the kid traveling. So make sure you're focusing on both kid and people that they've been exposed to. And I like to go back at least 6 months. I think infectious disease might be a little bit different than that. Maybe they go longer. Maybe 6 months is good. Maybe do a little bit shorter, but usually I'll call it a half a year. And then our cat. So cat scratch fevers, potential cause for prolonged fevers, rats, rat bite fever, many others, including rabies for tularemia. There's many farm animals that can carry diseases. And so this is a great area to really delve into what pet or animal exposures they have. If you say pets, they're going to say pets. Make sure you talk about all sorts of animals, whether it's farm animals, petting zoos, things like that. And then the little person over here climbing the half mountain, that's supposed to represent somebody who's cave diving or spelunking. So histoplasmosis is a good infection that can give you prolonged fevers, sometimes in immunocompetent hosts, but also in immunocompromised. So think of anything new that's going on, anything like new hobbies that they have, whether it's outdoor adventure or something that might expose them to other infectious agents. Iatrogenic causes. So the pill bottles representing drug fever. So did we prescribe them a medication, or are they taking a medication that's now giving them drug fever? So really delving into what medications they are taking. Is there anything new that we prescribed, or anything that new that they're taking over the counter? And then the bed is to represent more direct things that we're doing to them. If they recently have surgery and this is a post-surgical fever, that one should be somewhat obvious. But oftentimes we might get called for patients who are in the hospital. They've been in the hospital for a long time, and now they're having prolonged fevers. What kind of tubes do they have? What kind of lines do they have? Are there other things that we're doing to them that could be causing these fevers? Or potentially, going back to the infectious, is there a chance that they were exposed to a staff member who had an infection and brought it in with them, or a family member? And then the third one, immune triggering. So things that might trigger an autoimmune response specifically. So vaccines, infections, the needle and the virus there, anything that really revs up the immune system in somebody who's susceptible to develop an autoimmune condition, that could be the trigger that puts them over. So is there some sort of inciting event, maybe not immediately before they develop their fevers, but within the few weeks before? The snowflake is environmental factors. And if we go back to our periodic fevers, there's NLRP3 associated autoinflammatory diseases, previously called CAPS, might have cold as a trigger for their fevers, specifically FCAS, familial cold autoinflammatory syndrome. And then the sun. Sun is great. Too much sun, not so great, especially for patients with lupus or juvenile dermatomyositis. A bad sunburn, a lot of its sun exposure, is not an uncommon way that their initial presentation is triggered for those diseases. It's also something that if they have lupus or juvenile dermatomyositis, a lot of sun exposure can lead to a flare. And so something that might be unusual to the non-rheumatologist is to think of sun in a bad way. And then the little graduation cap there is supposed to represent stress. And so we do know that autoimmune conditions are often triggered by stress, worsened by stress. We see the kids who are entering college and then developing their autoimmune condition shortly after that as they're going through the stressful transition from home life to college life and the workload that's demanded of them. And the next and final bit of the history is the response to prior treatment. So invariably, a lot of these children are going to get antibiotics, whether they came into the ED, their PCP, their urgent care. And sometimes the antibiotics are directed at fever without a clear source that is being treated. And did they not respond because this was not the right antibiotic? Quite possibly. did they respond? And that means for sure this is bacterial? Not necessarily. There's definitely some autoimmune or autoinflammatory diseases that are responsive to antibiotics, like chronic non-bacterial osteomyelitis can have a transient response to antibiotics. And then ANCA-associated vasculitis that has sinopulmonary involvement. One of the treatment modalities can be trimethoprim sulfamethoxazole. And so that could be a little bit of a misguider if you see that they're improving with antibiotics to think that it's truly bacterial. So looking at the long term and really gauging their symptoms and seeing, was this really responsive or only partially responsive? What about the response to antipyretics? NSAIDs versus acetaminophen, is one more potent than the other for improving their fever? In rheumatology, we usually think of NSAIDs as being a more potent antipyretic for autoimmune rheumatologic conditions, specifically things like systemic JA, Still's disease, whereas Tylenol may offer some benefit, but it tends to be more muted. Maybe they're not having a response because their dose is wrong. I think that everybody has encountered a family where they say, oh, it's not responding to Tylenol or ibuprofen. And then you ask them what dose, and they've continued the dose from when the kid was a toddler, and now they're in middle school. What about other things? IVIG, it's not common, but it's not uncommon to get kids who have already been treated with IVIG and they still have persistent fevers. They were treated thinking maybe this is Kawasaki disease, and so given IVIG, maybe they did have a response to that or to systemic steroids, which both of them are quite broad in their mechanism of action and treat many different things. So a response gives you some information, but it's not definitive towards an autoimmune type cause for their persistent fevers. And then something that some people are very happy to tell you about, and others are more reticent to because maybe they'll feel like they're being judged from the medical community, is what herbals and supplements are they taking at home? Is there something they're taking that could be causing a drug-induced fever? Are there other remedies that they've been using that have been helpful and might give you a clue into the responsiveness of this fever to either medications or non-medication remedies? So after you've done a nice thorough history, now it's time for the exam. The exam may give you the diagnosis. You may see a diagnostic rash. It may give you a focus for imaging. You may have somebody who's not having pulmonary findings, but then you hear very dull sounds in their lung base and you get a chest x-ray there. It may tell you how urgent the evaluation is. Hopefully it does tell you how urgent. The old adage of sick or not sick that we classically learn in residency. It may not give you much. Maybe that's giving you something by not giving you much. But I'd like to really reinforce this point that the exam and the history, both of them are quote unquote free. It requires your time, but other than time, there's no real cost to it. Now, unlike something like a CBC or other testing, the more you get it, the more you do it, the more you do a good history, the more you do a good exam, the better it becomes. If we ignore history and exam and we rely on our testing, we let those skills atrophy. And so that's why I wanted to put the major focus on history and exam for this talk. And for a good exam, really doing a comprehensive exam is key. And repeat exams are really critical. And whether that repeat is comprehensive or focused is really up to the presentation. Even though I've just said comprehensive, I'm going to give a few focus areas to think about. I think these are some of the highlight areas where you might be finding sources for persistent fever. So the lymphatic system, that can give you clues into cancer diagnoses, infections like EBV, autoimmune conditions like lupus or ALPS, or a localized infection, something like cat scratch disease, where you might have lymphadenopathy proximal to the area of the scratch. From the musculoskeletal side, osteomyelitis is such a big potential cause for prolonged fevers in children that a good exam is going to be critical there. Usually they're going to have the pain symptoms that really point towards where to look, but looking throughout the entire musculoskeletal system is key. Arthritis. This is really near and dear to the rheumatologist's heart. And so if you're not a rheumatologist, you may have a little bit more difficulty assessing for arthritis. Even as rheumatologists, sometimes we have difficulty assessing for arthritis. So don't feel bad. But the arthritis may be primary in something like Still's disease, or maybe secondary or pseudo-secondary, like in Kawasaki or acute rheumatic fever, where the arthritis is a component, but not a critical component to the diagnosis. Pulmonary exam, many different things that can hide in the lungs, whether it's fungal, bacteria, mycobacterial. Oftentimes there's symptoms, but sometimes not, or they've kind of compensated if it's been a prolonged infection. Cardiac exam, another great classic area for infections with prolonged fever symptoms to hide, especially endocarditis, but you may pick up myocarditis or pericarditis on your exam as well. And then the skin and mucosa, there's so many different etiologies that can be discovered from a good skin exam, good mucosal exam. To highlight some here, I'm just going to go through these since this modality is not set up for interaction here. So this first one is the rash of Still's disease, what we often call a salmon-colored rash. It's maculopapular. It's transient, comes and goes with the fever. It's a very classic presentation. This, you may recognize it right from the get-go, but the history should definitely help you as well. But this is the rash of erythema marginatum that we would see in acute rheumatic fever. So if you see somebody who's got persistent fevers, they've got sore joints, it doesn't seem so specific, but then you look at their skin and you see this rash, you should immediately start thinking of acute rheumatic fever, and that will help you with both the workup, the history, and the treatment. Here, this could look like a bruise. This is erythema nodosum, which could clue you into multiple different things, such as TB, sarcoidosis, inflammatory bowel disease. It may present fairly subtly to you visually. To look for it can then help you think of diagnoses to consider. For those of you in the Midwest, especially the northeastern United States, and then anybody who's recently studied for any sort of testing, this picture probably jumps out as you as Lyme disease. And so on the back, but it can be hiding. It can also be present without a good history of a tick bite. Most times Lyme is present after a tick bite, but most of the time the patients don't remember being bitten by a tick. This is the little pustular lesions of cat scratch disease. We often think of that suppurative lymph node that accompanies it, but at the site of the scratch, there's often some little papules that will develop. And then this is also geographically relevant for some, but not others. This is Rocky Mountain spotted fever. And so that rash on the palms is very classic. Now moving on to testing. So I'm going to spend a very little amount on testing because I really want to reinforce the history and the exam as your keys to how to approach these children. But if you do see somebody with a fever of unknown origin, this set of testing here on the screen is really the standard. You should get this. This is what you should be looking for initially. Further testing is really going to be dictated by your history, by your physical, by how sick the kid is. Is this somebody who's in the ICU and really needs an urgent evaluation and you're going to do a little bit more of a shotgun approach? Or is this somebody you're seeing in clinic or in the ED and you can be a little bit more measured with your approach? If you have not read this book, The Laws of Medicine by Siddhartha Mukherjee, strongly recommend it. The way that I think about testing is in his Law 1, a strong intuition is more powerful than a weak test. So if you are always shotgunning your tests and then you get a positive, you may not realize that that positive is a red herring or is a false positive. Or if you're always doing it and then you see negatives, but if you have that strong intuition, you think, I really think that this patient should have a positive whatever test, then you can look into that more and think, well, why did this test come back negative? Is there a reason? A classic example for us in rheumatology is when the ANA titer is extremely high, it may come back as a negative. And then if we can ask the lab to keep diluting it over and over and over again, eventually they'll find the titer. And so you wouldn't think to necessarily look for that if you aren't thinking about the test that you're ordering. Go out, buy this book, read it, listen to it. I think it'll really help frame how you think about multiple areas of medicine. And now, going back to the case, remember the 19-month-old girl. She had a fever, she had a rash. It developed after her URI. We learned that the fever and rash waxed and waned together, often treated with NSAIDs. There was a persistent pattern to her fever. So it wasn't quotidian, it wasn't double quotidian. It seemed like she always had it unless she had gotten ibuprofen. When she wakes in the morning, she does have a 30 to 60-minute episode where she needs to be held before she'll walk. If mom sets her down, she still won't walk for 30 or 60 minutes, but she prefers to be held. And then, like I said, she's transiently responsive to ibuprofen, and she's nearly her normal self when she's afebrile. The exam, again, not her, but representative image. So this erythematous maculopapular rash. On subsequent exams, when she was afebrile, notice that the rash faded almost to resolution. She also had some shoddy cervical lymphadenopathy. But just as important as the positives are, the negatives are also important. So for her, she had no Kovner's phenomenon or dermatographism. So that's where you scratch at the skin in an unaffected area, and then the rash will develop in that area. Or dermatographism, not necessarily disease related, but similar. You get the hive-like rash to scratching. She didn't have any joint swelling, stiffness, or decreased range of motion, and there was no focal sites of infection on her exam. Also pertinent, no conjunctival injection or mucosal involvement to kind of steer us away from Kawasaki disease. And while she looked a little bit uncomfortable, she was not ill appearing. And so from this history, from her exam, there's a fairly high suspicion for Still's disease. That rash that comes and goes with her fever is classic. While it's not quotidian, it doesn't have to be. In fact, most of the time, it's more of a chaotic pattern. And then as the disease progresses, so if she were to go longer without treatment, then it would probably move into that quotidian or double quotidian pattern, double meaning twice a day. But lab testing for her does show elevated inflammatory markers, both ESR, CRP, white blood cell count, and platelets. And then really much more telling towards her diagnosis is ferritin, which initially tested as 1,000, jumping up to the 2,000s during the course of evaluation and treatment. And then importantly, she did have cultures that were negative. So she was given the diagnosis of Still's disease or systemic JIA based on her clinical features and then supported by her labs. And then further support for this came when her IL-18 returned at over 17,000, which there's few things, almost nothing, that would give you this presentation and not be Still's disease with this high of an IL-18. It's about as close to a diagnostic test as we can get in rheumatology, or so we think right now. That's the end of my presentation. Thank you for tuning in, and I will see you in the question and answer session.
I am so pleased to welcome Dr. Scott Canna next to talk about biomarkers in HLH and MAS. Dr. Canna is an associate professor and physician scientist at Children's Hospital of Philadelphia. He trained primarily at CHOP and the NIH. His clinical practice includes general pediatric rheumatology, but he also co-leads the CHOP Immune Dysregulation Program, which is an inpatient-outpatient multidisciplinary dysregulated immunity response team. His research program is focused on understanding the mechanisms of auto and hyperinflammatory diseases, with a focus on the inflammasome-activated cytokine IL-18. His research runs the translational gamut from basic sciences in animal models and cell lines through human observational data and biomarker studies to pilot clinical trials. I think I could go on and on about all of Dr. Canna's amazing work, but I think we were all particularly interested in learning more about how Martha is greater than Snoop. So without further ado, I will turn it over to Dr. Canna.
All right. Well, thanks for joining, everyone, and good morning. It's evening when I'm recording this, but everything's relative. My name is Scott Canna. I'm a pediatric rheumatologist and I guess immune dysregulationologist at Children's Hospital Philadelphia and University of Pennsylvania. Very excited to be joining this session today about fevers and cytokine storms, and really excited to join everybody afterwards for the Q&A with some good friends. So today we're going to learn about why interpreting biomarkers in inflammatory syndromes like HLH and MAS, you want to be a little bit more like Martha than Snoop, and hopefully that will make sense in time. A few disclosures, nothing particularly lucrative. And our learning objectives, we really can't dig into this without start talking about what we even mean by biomarker. And I apologize for that, but it is the way it is. And then we're going to dig right into sort of a whirlwind of biomarkers, routine stuff, inflammatory cytokine panels, some things that maybe are considered more specialized, and hopefully leave you with some pearls about their uses and limitations. So a biomarker, what the heck even is that? It has a definition, medical signs that can be objectively measured as an indicator of a normal or disease process, response to therapy. They include all of our favorite things: blood pressure, temperature, imaging findings, and they can measure all kinds of things: risk. They can help you with diagnosis, monitoring, prognosis. They can predict things. They can help you with safety. So pretty much everything that we measure is basically a biomarker. And so that isn't really a very helpful definition. What maybe is a little more helpful, at least with what we're going to discuss today, is that you never really get away from the characteristics of a test. And so I was taught, and it has stuck with me, that tests have certain characteristics, sensitivity and specificity. And maybe the easiest way to remember what those are is that specificity is spin. So a specific test, if it's positive, rules the disease in, or SNOUT, sensitive test, if it's negative, rules it out. So pretty much every piece of information we collect is in the category of biomarker, but we can't talk about all those. So we're going to focus on cytokine storm. And within biomarkers of cytokine storm or inflammation, there's been a ton of work. And really, it's led to this sort of crisis of specificity, where we have here just pictured a few, but literally dozens of inflammatory biomarkers, and very few of them have any specificity. And so this search for the holy grail of an inflammatory biomarker that would tell me what diagnosis I'm dealing with has been ongoing for decades. And many of you are familiar with it, particularly in the context of little babies with fevers. But we're here to talk about cytokine storm and HLH and MAS, and whichever term you prefer, I can work with. And you really can't talk about these without talking about biomarkers, because these syndromes are defined by the biomarkers. And so here, this is a comparison of the HLH-04 criteria, the 2016 macrophage activation syndrome criteria, and the H score. And in large part, they all include the same biomarkers: ferritin, neutrophil count, hemoglobin, platelets, liver function, fibrinogen, NK cell activity, soluble IL-2 receptor, yada, yada, yada. Some of the cutoffs are a little bit different, and we'll get into that a little bit. But for the most part, they're describing the same syndrome. Why might those cutoffs be a little bit different? Well, for one, they were developed in different contexts. The HLH-04 criteria were really meant to diagnose children with primary and sort of extending into secondary HLH, whereas the H score was really derived from adults with cancer and infections, and almost none of those patients had primary HLH. So even though the components are the same, you'll see some of the cutoffs are a little bit different. Like, you need to have a much higher ferritin to sort of get entry into the H score than you do for MAS or for HLH. The H score is a pain in the neck to try to calculate, but luckily if you go on MedCalc or whatever your favorite online calculator for medical stuff is, you can sort of have that score calculated for you. And it's nice to have something that's a little bit more continuous than a sort of off on, do you meet criteria or not? So it's worth stepping back again to think about, why do we have biomarkers and criteria, and what are the pluses and minuses there? And so whenever you have them, there has to be a cutoff. And how was that cutoff defined? Was that cutoff defined by comparing your patients to healthy controls or to similar diseases that you're trying to compare to? How different is your patient than the controls, or how different is that patient than disease controls. All these things matter in how useful that biomarker cutoff might be. Second is, which assay are you using and how variable is that assay from one lab to the next? That's one of the reasons it's hard to have inflammatory cytokines as part of criteria, because they really vary from one lab to the next. And then maybe most importantly is, how much does the specific physiology of whatever that biomarker is measuring overlap with your specific diagnosis? And so to illustrate that, one biomarker that has pretty good diagnostic specificity is your strep throat swab, which measures the beta-linked N-acetylglucosamine in your throat. And that has a pretty good overlap with strep pharyngitis if a patient has symptoms. Whereas something like high ferritin doesn't have as great an overlap with a diagnosis like HLH-MAS. And so the utility of any particular biomarker really depends on how much the physiology of that biomarker, what it's actually measuring, overlaps with the specific diagnosis that you're trying to make. And finally, nature doesn't really work hardly ever like a light switch. It's not as if patients are in HLH or not in HLH just binarily, but all of these things vary continuously. And if you have more than one biomarker that goes into criteria, you can have a little bit more of coagulopathy with a little less T cell activation, or vice versa, and still be within that diagnosis, but with differences that matter. And so as we start to dig in, here's some of the sort of call outs or things that you might notice that maybe help you with what kinds of things that biomarker is helpful for. Is it useful for diagnosis a little bit or a lot? Is it useful for monitoring the primary disease activity or complications of that primary disease? Does it help you predict prognosis? Does it help you understand more about what's going on in the disease? So now we're going to dig in, and we're going to start with the biomarkers that we get all the time, whether we pay attention or not. Starting with the white blood cell count, I'll be the first to say I don't ever want to know the white blood cell count. I only want to know the absolute values of the constituents of that white blood cell count. And for the most part, when people say white blood cell count, what they mean is neutrophil count. We use this in a variety of contexts. Surgeons love it. And it has actually very little diagnostic value because it's so nonspecific, but maybe actually correlates with better prognosis in Still's disease, systemic JIA. The patients with a high white blood cell count actually responded better to treatment. I'm not going to get into the rest of these too much, other than to say that all of these are components of the various criteria that we've discussed, and they indicate specific physiologies that are part of that diagnosis. Platelet counts are down because of consumption like DIC, the same way fibrinogen is, but also can be down because of organomegaly. Triglycerides, not particularly great as a criterion, but probably reflect the same hepatitis that you might see with LFT elevation. CRP, LDH aldolase, all things that you're sort of used to, although I'll have more to say about these in a bit. So we would have to start any biomarker talk. If we're going to really talk about a biomarker, we're going to have to talk about ferritin. Ferritin is pretty sensitive for the syndrome of HLH-MAS. It's a little bit hard to say someone has that type of physiology with a normal ferritin. What is ferritin? It's actually a pretty massive molecule made up of heavy and light chains, and it's kind of there to sequester free iron, not just because free iron is pretty toxic, but because bacteria really need iron to do their whole replication toxin thing. So sequestering that iron and keeping it away from bacteria and keeping it from oxidative damage is sort of the reason we make so much ferritin. As a biomarker, as I said, it's very sensitive. The dynamics are also important, both rate of rise and rate of improvement in patients that hopefully are responding to treatment. We know that if after a week or so of treatment, your ferritin hasn't dropped by half, you have a worse long-term outcome in primary HLH. And then what does it tell us about the physiology? Well, it maybe tells us something about the role of iron. Ferritin synthesis is driven by free iron, but so inflammation also drives ferritin. And so if you give a patient with MAS or HLH and blood transfusion, that might bump their ferritin regardless of their inflammatory activity. And this is rarely tested anymore, but glycosylated ferritin might be more associated with Still's disease or other inflammatory contexts. Not easy to find a place that measures that. It's also a prognostic biomarker, even outside specifically inflammatory diseases. And so a couple studies recently have shown, I'm sorry, I've obstructed my own slide here, but basically there's an ROC curve of how likely you are to get out of the ICU as a child if you have a ferritin above, I think the cutoff here was like 400 or so, and an elevated CRP. So ferritin's part of what defines someone who is maybe not going to do so well in the ICU just in generally. So how can we make ferritin a little bit more specific? Well, Randy Cron and colleagues a few years ago said, well, when we see a low sedimentation rate, that's usually an indication of DIC or ferritin, fibrinogen consumption. And so if we see a high ferritin and a lower than anticipated sedimentation rate, that improves specificity for MAS versus just active systemic GIA. And that is definitely true. And these are readily available and easy to get. So it's a way of sort of getting a quick look at that physiology without having to think too hard about what that physiology is that's going on. So of course I have to talk about the pro-inflammatory cytokine panel. Lots of places have one. They all run them a little bit differently, and they all contain different things. I've tried to cover most of what's in most of the inflammatory cytokines panels that are around, what that cytokine sort of does, and whether this cytokine measurement as a biomarker is useful. And obviously you're not supposed to memorize any of this, but I want to make the point that a lot of what's in our pro-inflammatory cytokine panels is there not because those are great biomarkers, but because these panels were designed for research purposes to try to provide sort of coverage of the key players in cytokine biology. So you had your type 1 immunity with gamma and your type 2 with IL-4, you had your anti-inflammatory IL-10, but not all of these are great biomarkers. And they were retained into these clinical cytokine panels largely out of convenience. They already had the platform set up. They'd already multiplexed it. And so we're going to keep in useless things like IL-12 or IL-1 beta, where we know those are important cytokines, but as biomarkers, they're almost never useful. It also matters how you measure it. And so this is a real world example of a patient who at almost exactly the same time had a cytokine 12 panel sent, which uses fluorescence as a readout, and had a pro-inflammatory cytokine panel sent to a different lab that uses electrochemiluminescence as a readout. And for the most part, they line up, but certainly some things are pretty different. And one of them here is interferon gamma, where this is just a much more sensitive readout than this one. And you might be falsely reassured that this is normal when the level's actually not astoundingly high, but certainly not normal. So what does the HLH cytokine panel look like? Well, it looks like a lot of interferon gamma, assuming that it's high enough to break threshold in your assay, and a lot of IL-10, and maybe some IL-6 and maybe some other stuff, but largely it's a gamma-10 driven cytokine panel. And this is an example of a patient now several years ago who was eventually found to have familial HLH type 5. And lo and behold, a really high serum interferon gamma level, a lot of IL-10, and pretty modest elevations of other things, and normal levels of these cytokines like IL-1 beta and IL-12 that are almost never useful. As it would happen, about a week later in the same unit, we had another patient who also ended up having FHL5, and we had a cytokine panel at almost the same time. And you still see a lot of interferon gamma, you still see a lot of IL-10, but now this patient has a ton of IL-8. And so I think we're still trying to understand what makes an HLH patient with or without IL-8, what's driving those differences? What is it about chemokine production, neutrophil recruitment that's different from one patient to another? Does one of these patients have some gut translocation of bacteria that's driving this and the other one doesn't? So it's also pretty important to be able to look at these things longitudinally. They're probably more useful for monitoring than they are for diagnosis, but this is a case in which longitudinal measurements were diagnostically helpful. So when this patient presented, interferon gamma was pretty high, IL-10 was reasonably high, reasonably modest elevations of IL-6 and IL-8 and other things like that. With time and treatment, those sort of HLH signatures improved. The gamma came down pretty nicely within a week or so. But at this time point, this patient actually had a fever and was starting to look kind of shocky and terrible. And we said, gosh, is this a recrudescence of the HLH, or is this something else, some sort of complication? And this was a situation where the biomarker panel basically told us this patient probably has a brewing bacterial sepsis, and about 12 hours later, the blood culture turned positive. So to summarize cytokine panels, know your assay, know what's in it, know what physiology each of those things measures. You don't get to not pay attention to cytokines, sorry. And know how sensitive your assay is, especially for some of the things that are maybe more discrepant, like interferon gamma. Understand that not all of these were chosen for clinical utility, and I've beaten up on IL-1 beta and IL-12 as not so great biomarkers, even though they're very important targets and cytokines, and that they're useful for establishing patterns, gamma and 10 and HLH, IL-6 TNF and IL-10 and bacterial infection, IL-8 maybe tissue damage, and if everything is up, things are not going to go well. But what you don't want to do is take a cytokine panel and just block it because it's high. Every time this comes up, I can only think of drop it like it's hot. And that's why Snoop comes to mind. He sees that IL-10 is off the hizzy and says we should block that. But we know that blocking IL-10 is probably not going to be super helpful, and that's probably up as a compensatory response. And we have to actually read some patterns. So time to move on to some other biomarkers that we love. Procalcitonin, not going to spend a lot of time on this. This was really supposed to be the holy grail of distinguishing a viral versus bacterial infection. Turns out that it's certainly not that specific, and maybe even less specific if you look outside Caucasian populations. It doesn't mean it has no specificity. It's just not always specific for bacteria. So acute Kawasaki disease levels are every bit as high as they are in bacterial infections, but higher than viral infections. So some helpfulness there. And again, an MISC and KD still pretty high. That FHL5 patient with the really high IL-18 I just told you about, procalcitonin of 180, which is way off the charts here. So patients can have mixed inflammatory pictures. So really big dynamic range, changes really quickly, so useful for monitoring. Probably specificity-wise, not so different than CRP. But if we're still talking about KD, I'd be remiss to not talk about IL-17. These are relatively new data, but I think that we're going to be seeing more of 17 measurement as helpfully diagnostic in distinguishing KD and KD-like states from lots of other disease control states, including dermato, non-systemic JAA, systemic JAA, MAS. This team, led by Pui Li's group, saw maybe a trend towards higher 17A levels in those who were going to go on to get coronary aneurysms. And what exactly this is saying about the physiology of Kawasaki disease, I think we'll have to keep our ears open for. So calcium binding proteins go by a number of different names. Calprotectin is a heterodimer of S100A8A9, aka MRP814. S100A12 goes by calgranulin or NRAGE, which is probably the name they should have stuck with because it's awesome. But these are proteins that have important intracellular functions, binding calcium and helping homeostatically. But when they get extracellularly, they actually function a pro-inflammatory role as DAMPs, and they're largely made and released by myeloid cells. So how are they useful? This is S100A12, pretty just helpful in FUO patients in distinguishing those with FMF or systemic JA from a variety of disease controls, whereas CRP was pretty lousy in that regard. And this is calprotectin, that S100A9 heterodimer, again showing it's pretty high in systemic JA, much more than infection. Can be pretty high in NOMID, but pretty variable. And this is the same thing, just by that MRP8 name, that it's stratospherically high in patients with STPIP1 mutations that have either Papa syndrome or this hyperzinc hypercalprotectinemia syndrome. So calprotectin in the blood, not the stool, still coming from neutrophils predominantly or other activated myeloid cells, and may be helpful in identifying a certain subset of autoinflammatory diseases, particularly at really high levels. May also be useful in predicting relapse in systemic JA. This is survival analysis in patients who came off therapy based on their MRP8 levels. And obviously, if they were lower, you were much less likely to flare. So we might actually be seeing some physiology here because these S100 proteins correlate pretty well with glycolytic enzymes in the blood like LDH and aldolase. And so maybe what we're actually observing is myeloid cell activation or maybe even cell death. Really activated cells, myeloid or otherwise, have to do glycolysis to sort of do their program. And actually, that's largely the glucose uptake that you see when you do PET scans, even if you're looking for cancer. And we know that inflammatory cells, when they get sort of jazzed up, whether it's pyroptosis or necroptosis, they explode and they release their contents, including these glycolytic enzymes, as well as these DAMPs like S100 proteins. So now we have to dig into the more specialized biomarkers. And probably the best one to start with is CD25 or IL-2 receptor. So the IL-2 receptor has multiple subunits. IL-2 receptor alpha is the high affinity subunit. It's not expressed on all T cells. It kind of gets expressed on memory or activated T cells, but it's stuck to the cell membrane. So how does it get off? Well, it kind of needs proteases like MMP9, largely coming from activated macrophages and monocytes. And they cleave off the IL-2, and then we kind of have what we act like is a circulating T cell activation biomarker. And for the most part, I think that that's largely what it is. These are the levels in HLH compared to non-HLH inflammatory diseases, sepsis, or myeloid leukemia, showing that it has some diagnostic specificity, although there is some overlap. And again, as a monitoring biomarker, this is just a patient with EBV HLH. So treatment was initiated around here, and soluble IL-2 receptor over the course of a few days really tracks nicely and coming down. Within hyperinflammatory diseases, the soluble IL-2 receptor is probably a bit higher in the more virally or pure gamma E states like familial HLH and viral HLH, whereas ferritin might be a little bit higher in MAS by comparison. Now, switching to my favorite biomarker, IL-18, this one really is a bit different. It has pretty profound diagnostic specificity. What does it diagnose? It kind of diagnoses whether you have a patient who is in the ballpark of Still's disease, systemic JA, MAS, or one of the monogenic mimics versus pretty much everything else. And I won't go through all the different studies comparing these, but there was a meta-analysis done. And within this group of other non-systemic JMAS diseases includes cancers, infections, other autoimmune diseases, ALPS, you name it. I've drawn this line in here about 20,000 because that's a decent cutoff. It's worth thinking about what you're measuring. You're not just measuring free IL-18, you're measuring total IL-18, which is IL-18 by itself or bound to this IL-18 binding protein, this high affinity neutralizing antagonist. And so normally there's a lot more binding protein. In all those other inflammatory diseases, the total IL-18 goes up, but almost none of it is free. In a sort of quiet or quiescent Still's patient, you might have total IL-18 levels in the 2 to 10,000 range, but because binding protein levels aren't high, a lot of that will be free. But it's really in your sort of flaring Still's patients or MAS patients, we've seen levels up to about 1 million where you have lots of IL-18 binding protein, but there's just so much 18 it can't be sequestered. Now, not everything we call MAS has really high IL-18. MAS in lupus and dermatomyositis and even Kawasaki, the IL-18 is not particularly high. So this is probably telling us that maybe MAS isn't the most specific term to be using. And it's not just useful diagnostically, but in monitoring, it doesn't move particularly quickly, but it certainly correlates with periods of flare. And so this is a Still's patient over time, LDH on the bottom, IL-18 on the top, active disease, MAS, inactive disease. There's your 20,000 cutoff, and here's all the different drugs that this person got. So when do I send it clinically? Obviously, to try and make a diagnosis, and Bas Fostert's group in Utrecht is about to release data showing that it really does decrease your testing for other things that are not relevant once you know that the 18 is crazy high. I tend to check a nadir just to see how much better things have gotten with initial treatment. If they're flaring, I'll check it again if I have any concern about that. And then maybe as a even more sensitive minimal residual disease marker to help make decisions about flare. In general, maybe it's for the patients in which it's elevated more like a hemoglobin A1C, sort of a broad swath of how active their underlying physiology has been over time. And so finally, I want to wrap up with finding interferon activity, starting with type 1 interferon. Most folks will be familiar with the interferon score. This is a sum of interferon-stimulated genes. And so you're summing the abundance of the mRNAs of interferon-stimulated genes, which are much higher in patients with like Candle and Savi than they are in patients that are normal or have other inflammatory diseases like CAPS. And this strategy might be useful extending even beyond type 1 interferon into NF-kappa B responses or interferon gamma responses. But we can't really order that right now. What we can order is a flow panel where you send off your patient's blood. That includes some CD14 high monocytes. And among those monocytes, they just look at the expression of Siglec, CD169, or PD-L1, CD274, as these are pretty good readouts of the amount of systemic circulating interferon alpha beta or interferon gamma. And so this is the report you get back. It tells you whether you have the right kind of monocytes, because if very few of the monocytes are CD14 bright, then it might not be so interpretable. And then how much CD169 expression is there, both percent positive and MFI, and same for CD274. And if it's still not clear, you get this really nice note from Dr. Abraham saying, this is what we think your sample looks like. There's a strong type 1 or type 2 interferon signature. I have to say, we use this a lot more for type 1 than for type 2, where it may not be super sensitive. But what is super sensitive for type 2 interferon gamma, there are a number of interferon gamma responsive biomarkers. The only one we have time to talk about today is CXCL9. I'll just make the point that pretty much every nucleated cell in your body can respond to interferon gamma or type 1 interferon as well. So the response can really be kind of global, even if the production is pretty local. So comparing CXCL9, or what used to be called MIG, or monokine induced by interferon gamma, in like active still systemic J versus quote unquote full-blown MAS, you see that gamma correlates pretty well with ferritin, and so does CXCL9. The difference here is just this dynamic range where you get really much better separation of the high CXCL9 versus low CXCL9 states. And that makes it a really useful dynamic biomarker of disease activity. And again, this is that same patient with EBV-HLH, initiated treatment, and very quickly the CXCL9 plummets from hundreds of thousands down to just a couple thousands. Now, we all want to measure panels. We want to measure more things. I don't want just one cytokine. I want a dozen, or maybe 100, or maybe 7,000. And we have to be a little careful about that. Measuring more is not always better. And so as an example of this, this is a O-link panel where we measured IL-18 as part of that panel. And we also measured it orthogonally by another method that we knew picked up really high levels pretty well. And this is sort of a classic hook effect, where if you just relied on the IL-18 values from O-link, you would not notice that these were highly elevated in the hundreds of thousands of range. And when you just compare out these NPX values, you don't see that IL-18 is specific at all for systemic J or MAS compared to other diseases. And that's because it's sort of safely into this hook region. Pui Li has data showing effectively the same thing in a totally orthogonal cohort, both with IL-18 and with CXCL9. And so panels aren't always the answer. You have to understand that each analyte has its own sort of idiosyncrasies. Some are different in serum versus plasma. Some really need high dilution, others don't. All kinds of other technical stuff. Most of these are calibrated with healthy controls or common diseases, but a lot of our patients can have pretty extremely high values that may be outside what that test was designed for. And so unfortunately, there is not any time left to talk about some of these other lovely biomarkers that I like to talk about. Maybe next time we can talk about a membrane attack complex or other things like MTS13 activity, some of the functional tests for primary HLH, but another day. So in summary, every biomarker is a test. That test can actually tell you different things, whether it's diagnosis, monitoring, etiology. Magnitude matters. These things are not just off on. And they measure physiology, inflammation, macrophage activation, T cell activation, maybe myeloid cell death, and of course, the specific organ damage that you might be worried about, whether that's liver, renal, what have you. So to get back to our title, you don't want to just block it because it's high. Interpreting biomarkers is a lot more like reading tea leaves. And in the love affair between Martha and Snoop, I have to imagine Martha's had more time with tea. So with that, I'll thank the really great team we have in our immune dysregulation program, aka DIRT, and sort of affiliated rheumatology here at CHOP, and lots of lab members and collaborators. Hopefully we'll have time for questions.
Our final speaker this morning is Dr. Grant Schuler. Dr. Schuler is an associate professor of pediatrics with tenure in the Division of Rheumatology at Cincinnati Children's Hospital Medical Center and the Department of Pediatrics at the University of Cincinnati College of Medicine. He received his MD and PhD from the University of Iowa Carver College of Medicine and completed his doctoral research in the laboratory of Professor Leanne Allen in the Iowa Inflammation Program. He then served as intern resident and chief resident in pediatrics at Vanderbilt Children's Hospital before completing his fellowship in pediatric rheumatology at Cincinnati. His clinical interests include undiagnosed and refractory systemic JIA and autoinflammatory disorders. He serves as co-director of the Autoinflammatory Diseases Treatment and Research Center at Cincinnati Children's. His research focuses on the pathogenesis of severe inflammatory diseases of childhood, in particular systemic JIA and chronic lung disease in children with systemic JIA, with a focus on their disease course and biomarkers. Additionally, he studies mechanisms of undifferentiated recurrent fever syndromes and MAS. We are so excited to hear from him this morning as he talks about the management of MAS and current therapies. As a reminder, please stick around after the morning lectures and join us in our live Q&A. And now, Dr. Schuler.
Thank you very much to NICER for this kind invitation to speak with you today. I'm Grant Schuler, rheumatologist and translational scientist at Cincinnati Children's Hospital and the University of Cincinnati. I'm going to be speaking on managing macrophage activation syndrome, current therapies, and future directions. Here are my disclosures. So what we're going to be doing over the next hour or so is first reviewing some of the clinical presentation and diagnostic approach in MAS. So I think this is important as we consider our approach to treatment. Second, we're going to be thinking some about new understandings on the pathogenesis of MAS, particularly with a focus on the IL-18 and interferon gamma axis, as that helps inform some of our new approaches towards treatment. And finally, we'll be discussing those and particularly thinking about the role of cytokine-directed therapy in the management of macrophage activation syndrome. So we're going to start with a case. This is a case from a number of years ago and a fairly typical presentation of MAS. So this was a 12-year-old boy who presented with 3 days of fever up to 103, a rash, and just generalized malaise. He'd been recently diagnosed with the systemic form of juvenile idiopathic arthritis, or Still's disease, only about a few weeks ago. And at the time, he'd had a fairly typical presentation of Still's disease. He'd had a polyarthritis. He'd had a daily spiking fevers for several weeks. He had an evanescent rash, and he'd had some organomegaly. And after being diagnosed, he was started on daily anakinra and had an excellent, good initial clinical and laboratory response to this treatment. However, then he got sick. He had a positive sick contact. He had younger siblings who were in daycare and probably brought some daycare germ home with them. And so when he became ill about 3 days prior to this initial presentation to us, he went to the outside ER because he was having a fever. The report at that time was that he looked quite well. However, his labs, as you can see here, were not exactly normal. He had a very elevated white count. A platelet count that was in sort of a normal range, but as we'll talk about, kind of a normal range platelet count in the setting of someone who's quite inflamed is a little bit concerning. Elevated C-reactive protein, a decently elevated ferritin to a little more than 1,500. And based on this and a concern for a flare or early features of MAS, he was started on oral prednisone. He was seen in our office 2 days later and was maybe a little bit better, but still having fevers up to about 101 with some continued malaise and shortness of breath during those fevers. Based on that continued fever, we decided to increase his prednisone dose a little bit and repeated labs. However, that evening, he went home and his fever spiked even higher, and his labs that we had obtained came back and they were actually worse. And based on this, we made the decision to admit him. So what did those repeat labs look like? Well, here you see his white count, still a little bit further elevated. Hemoglobin fairly normal, but the platelets have dropped now to about 120. CRP continues to rise. His ferritin has increased significantly to now over 13,000. Transaminases are a little bit elevated. Fibrinogen in kind of that low normal range, but which we'll talk about in MAS, that's actually an abnormal fibrinogen, and elevated triglycerides. All of these labs consistent with a diagnosis of macrophage activation syndrome. So based on that, he was given IV pulse corticosteroids for 3 days. He was also started on cyclosporin to help control this inflammation, as the IL-1 therapy hadn't ever fully normalized his labs. And with this therapy, he improved over the course of several days, had a resolution of his fevers, improvement in the laboratory features of MAS, and was discharged on a tapering dose of prednisone, as well as continued anakinra. As I said, this is a fairly typical presentation of MAS in a patient with known Still's disease. So what is macrophage activation syndrome? So pathologically and immunologically, MAS is what we consider a cytokine storm syndrome, which is really marked by this excessive activation and proliferation of T cells, particularly CD8 cells, and well-differentiated non-neoplastic macrophages or histiocytes. Clinically, this can manifest as cytopenias, including pancytopenias, liver dysfunction, coagulopathy, and the extreme hyperferritinemia that we think about in many of these cytokine storm syndromes. In tissue, you see these very activated macrophages or histiocytes that are often engulfing other cells. Again, hematologists, when they first saw this, described this as hemophagocytic histiocytes and termed these disorders the HLH disorders, or hemophagocytic lymphohistiocytosis. We as rheumatologists looked at this and saw these macrophages and said, wow, these are really activated, and so called this macrophage activation syndrome. And even in sort of 21st century treatment landscapes, full-blown episodes of MAS can be fatal in 10% or even more of cases. So in rheumatology, MAS can be seen in association with really almost any rheumatic disease that can drive systemic hyperinflammation. Lupus, Kawasaki, other connective tissue diseases, some of the monogenic autoinflammatory disorders. However, in pediatrics, MAS is most commonly encountered in patients with Still's disease, systemic JIA, and then adults onset Still's disease. In adults, MAS in the setting of lupus may be more common just because there are so many more adults with lupus than there are adults with Still's disease. Full-blown episodes of MAS can occur in at least 10% of patients with Still's disease, whereas mild or occult or subclinical MAS can occur in a third or even more of these patients. So as I said, MAS bears a striking clinical and laboratory similarity to the HLH disorders, or hemophagocytic lymphohistiocytosis. And this connection was first made by Alexi Grom and others now almost more than 20 years ago, when they looked at the clinical features of MAS and really saw all of these clinical features that had been described in the HLH disorders: fever, hyperferritinemia, organomegaly, particularly splenomegaly, cytopenias, the hypertriglyceridemia and hypofibrinogemia, the hemophagocytosis in the bone marrow or other tissue, which we saw, elevated soluble CD25 or the IL-2 receptor as a marker for these very activated T cells, and then lower absent NK cell function. In fact, now we think of MAS as a form of HLH that can occur in the setting of inflammatory rheumatic diseases. However, this nomenclature can be really complicated and can make it very challenging sometimes to describe these patients in a multi-specialty environment, which is why I'm particularly excited to be speaking with this group today. Because what we call things is important, partially because it's how we communicate with one another. So as I said, secondary reactive forms of HLH are an HLH disease that is not caused by a primary genetic lesion, but instead triggered by something else. And MAS is this when it occurs specifically in the setting of a rheumatic disease. Or as I say, this is secondary HLH when it's diagnosed by a rheumatologist. I've even seen the phrase cytokine release syndrome buried about in talking about some of these patients. I think of that as secondary HLH when diagnosed by an oncologist, because they see this through their window of cytokine release syndrome, as they see as an iatrogenic form of cytokine storm syndromes that can occur in the setting of CAR T cell therapy or other cell-based therapies. That's where this sort of broad window of cytokine storm syndrome can be helpful, because it allows us to recognize that no matter what we call these disorders, they fit under the same umbrella, and they have a lot of similarities in their clinical presentation, but most importantly in their immunopathogenesis, and therefore the approaches that we can take to treat them. So this is a slide that my colleague Mike Jordan and I have used a number of times when talking about HLH versus MAS. And I would say that HLH and MAS are, yes, they're distinct diseases, but they share a final common pathway, which is this hyperferritinemic, hyperinflammatory cytokine storm with a critical role for that cytokine storm in driving disease pathogenesis. So looking again at these clinical features that are really the diagnostic criteria for HLH, we find that many of these can be problematic when trying to recognize MAS. So for example, take fever. MAS is a complication that occurs in the setting of rheumatic diseases, many of whom have fever as a primary clinical manifestation. Hyperfibrinogenemia is characteristic and diagnostic of HLH and MAS, but it's also seen in Still's disease patients who don't have MAS. Cytopenias can be very dramatic in HLH, but in MAS, they are sometimes offset by the dramatic acute phase response that we see in Still's disease that's driving the white count as well as the platelet count higher. So if we go back to that first patient, as they were initially presenting, their platelet count wasn't all that low, and in fact, it was in the normal range. But a normal range platelet count in the setting of a patient who has a very strong acute phase response is really an abnormal platelet count. Similarly, when we think about the fibrinogen level, this is in a setting of systemic inflammation, the fibrinogen should be pushed higher. If it's in the low normal range, that's an abnormal fibrinogen. Hemophagocytosis on bone marrow or tissue we know is insensitive. That can be a false negative in the setting of disease. And NK cell function can in fact be transient or even normal in Still's disease. So these HLH criteria are less helpful for recognizing and diagnosing MAS in the setting of Still's disease than they are for seeing primary HLH. So we do have criteria that are helpful for thinking about MAS, particularly in the setting of Still's disease. So the 2016 classification criteria, which were developed specifically in systemic GIA, but I think are useful for the broader Still's disease spectrum. So this was an evidence-based criteria that was put together through a collection of over 1,000 patient vignettes from an international retrospective case series that consisted of patients with systemic GIA and MAS, patients with systemic GIA but without MAS, and then other mimickers, primarily infections, but other inflammatory disorders that can mimic MAS. And using a data-driven approach, this then developed and validated what we now say are the 2016 MAS classification criteria, or sometimes called the Ravelli criteria. And this was defined as a febrile patient with known or suspected systemic GIA who is classified as having MAS if their ferritin is over 684, and they have at least two of these other laboratory variables: platelet count that is less than or equal to 181, AST that's greater than 48, a triglyceride level that's over 156, and a fibrinogen that's less than 360. One of the really nice things about these criteria is that they don't depend on difficult to obtain or complicated lab tests. These are largely things that can be obtained routinely in an outpatient setting, which is great. The cutoffs are a bit unwieldy. You know, we rheumatologists, we love our criteria. Professor Ravelli had wanted them to sort of round these to something that was maybe more easy to remember, but the biostatisticians said, nope, these are the optimal cutoffs, so we're going with them. So, you know, they're not quite easy to remember, but these are in fact the optimal cutoffs for classifying MAS. I would also note that these are classification criteria, not diagnostic criteria. However, they are helpful in the diagnosis because they help you sort of recognize the features that you should be seeing in somebody who you suspect is having MAS. There are some other limitations of these criteria. A major one is the effective biologic therapy. So these classification criteria were evidence-based, but they were derived from patients who were almost entirely pre the widespread use of anti-IL-1 and 6 biologics for Still's disease, which have really become the first-line standard of care for this disease in the US. So we performed a study several years ago where we did a comprehensive literature review identifying patients who had MAS while taking IL-1 and IL-6 biologics. And what we found were that the criteria performed fairly well for patients on anti-IL-1 therapy, both anakinra and canakinumab. However, some patients who were judged to have MAS by their treating physicians didn't meet the ferritin threshold that these criteria prescribed. However, they were significantly less useful for patients on tocilizumab as an IL-6 inhibitor. In fact, only 57% of patients that were judged by their physicians as having MAS on tocilizumab satisfied these criteria. Several of those patients were afebrile, and others did not meet that ferritin threshold. I would also note that while biologic use may alter this presentation of MAS, it does not appear that biologic therapy alters the overall rate of MAS, both making it less likely or conversely making it more likely. So interestingly, we still consider MAS with really the same level of incidence in our current treatment landscape as we did 15 years ago prior to the introduction of these therapies. One last thing that's, I think, very helpful to think about when you're approaching a patient with suspected MAS was this EULAR and ACR Points to Consider manuscript that was led by Scott Canna, which was published a couple of years ago. And this was really taking the approach of how do you think about a patient who fits under this cytokine storm syndrome umbrella, and whether this could be HLH, whether this could be MAS, whether this could be a hyperinflammatory mimicker. How do you approach these patients? And what it really said is you need to take a three-pronged approach to assess, investigate, and treat. And the first is to assess, right? Is understanding, does this meet criteria for what we could consider MAS or HLH, based on laboratory findings, based on defining the organ involvement, such as liver, brain involvement, investigating for what the causes are. So, the big three that we think about as triggers of an HLH-like cytokine storm are infection, malignancy, and other, primarily rheumatic diseases within that other bucket. So looking broadly for infection, looking very carefully and diligently for malignancy, preferably before you start empiric corticosteroids, and then considering whether this could be a rheumatic or inflammatory disease. And then an initial treatment approach that tries to stabilize the patient, treat treatable causes such as infections, and support them while trying to make this diagnosis before moving immediately to steroids, or even sometimes more concerningly, cytotoxic chemotherapy agents, while trying to make sure you get the diagnosis right. If a patient is clinically deteriorating, and you need to treat before you're able to sort of check everything off within that investigative bucket, consider empiric immunomodulators, such as steroids, starting at moderate doses, but escalating if needed, anakinra, which we'll talk a little bit more about, or IVIG, which is actually sort of a great sort of immune temporizing agent, which is, by being steroid sparing, doesn't sort of muddy the waters if you're still trying to rule out malignancy. So we'll talk more about these treatments here at the end of the talk. All right, so now let's shift into the second part of the talk and think a little bit more about the pathogenesis of MAS, and particularly this role of this IL-18 and interferon gamma axis in the disease. So if we consider the pathogenesis of the primary or familial forms of HLH, these are genetic diseases which are defects in cytolytic T cells, CD8 cells, or NK cells. The first of these that was identified was actually perforin deficiency, the protein that's required to form these pores that deliver granzyme into the target cells. Since then, a number of other genetic disorders have been defined where loss of function mutations in one of a number of other proteins that are key in this granule trafficking pathway cause an inability of these effector cells to kill target cells in a perforin-dependent manner. And this leads to persistent inflammation. Because these effector cells are unable to kill their target cells, we have this sort of frustrated cytolytic activity where they continue producing cytokines, particularly things like interferon gamma, in an uncontrolled and continuous way because they can't get turned off because they can't kill these target cells. This leads to persistent inflammation and ultimately drives the cytokine storm that we see as familial HLH. So what about an MAS? Genetic defects is some of the story in MAS, but it's not the whole story. So a number of cases of patients with systemic JIA and MAS have been reported where patients have rare single or heterozygous variants in perforin or one of these other HLH-reported genes. This was initially reported by Melissa Hazan and Bas Fostert. A more comprehensive study by Alexei Grom and Ken Kaufman, now almost 10 years ago, performed whole exome sequencing in a large cohort of patients with systemic JIA who either did or did not have a history of MAS. And they found that in patients who had a history of MAS, more than a third of them had these rare predicted pathogenic but heterozygous or hypomorphic variants in perforin or one of these other MAS-related genes, which was significantly higher than was seen in patients who have systemic JIA patients who never had MAS. Interestingly, similar findings of about a third or so of patients with MAS having these variants have been found in a number of other series, including a series that we reported several years ago of primarily young adults who had fatal H1N1 influenza, signs of hemophagocytosis on autopsy, and clinical features of cytokine storm or MAS in their labs. A similar proportion had hypomorphic variants in these HLH-reported genes. So these may be contributors to the pathogenesis of MAS, but it's not the whole story because 2/3 of patients don't have any identified genetic causes. Now let's think about what is happening in MAS, particularly in the setting of Still's disease. So Still's disease is marked by this really exuberant innate immune activation, particularly of the IL-1 family cytokines, and most notably of IL-18. So IL-18 is an IL-1 family cytokine. It's produced through activation of inflammasomes, particularly the NLRC4 inflammasome, in response to its activation. And then one of its most critical factors is its ability to induce activation of CD8s and NK cells to produce cytokines like interferon gamma. In the settings of infection, that's very helpful because it makes a more activated macrophage phenotype that's able to help those macrophages clear up and respond to infection. However, in the settings of MAS, it drives a hyperinflammatory cytokine loop, which then further amplifies this inflammatory response. This pathogenesis is really illustrated very profoundly by the identification by Scott Canna and others of patients with gain-of-function mutations in the NLRC4 inflammasome. These patients have a persistent IL-18 elevation and recurrent episodes of MAS. So in Still's disease, what we find is that while IL-18 elevation to some degree is almost universal, the degree of IL-18 elevation may subset patients for the risk of complications such as MAS. So this was originally noted by our colleagues Masaki Shimzo in Japan, who, when he looked at patients with systemic JIA, and he looked at the relationship of their IL-18 levels, which are shown here on the bottom, to their IL-6 levels, which is shown on the y-axis, he saw a range of this, but saw that you can largely then distinguish these patients as an IL-18 predominant subset or an IL-6 predominant subset. Those patients who had a higher ratio of IL-6 to IL-18 were generally older, had more arthritis, and notably had no MAS. On this graph, the patients who have a green dot here, which are all on the lower right, are the only patients who had MAS. This subgroup of patients where IL-18 predominated over IL-6 had a much more striking risk of MAS. We found similar things when we looked at our cohort in Cincinnati. This was work a number of years ago by Shimi Yazin when she was a fellow with us, where she examined patients with a broad range of disease activities. She found that we see higher levels of IL-18 in active versus inactive Still's disease, but we also see higher levels in patients who have a history of MAS. And we see the highest levels in those who have active present MAS, but beyond that, patients with active disease and a history of MAS had higher levels than those with an active disease without a history of MAS. So showing this progressive increase in risk based on your levels of IL-18. So as I noted, one of the key immunological functions of IL-18 is its ability to induce interferon gamma. So it's been known that for some time now that interferon gamma is likely a critical cytokine in the primary familial forms of MAS. This was really noted by Mike Jordan a number of years ago when he made a perforin deficient mouse model and showed that interferon blockade in this mouse model could completely block the clinical features of HLH. So what about in MAS? So we've found very similar things, which is that marked elevation of interferon gamma, and particularly these interferon gamma-induced chemokines, such as CXCL9, 10, and 11, can really distinguish MAS in systemic JIA from systemic JIA flares that don't have features of MAS. So let's look at some of this data. This was a project we did together with our Italian colleagues, Claudia Bercaglia, Fabrizio De Benedetti in Rome, and Angelo Ravelli in Genoa, where we collected samples from a large cohort of patients with Still's disease who are having MAS episodes or flares of their Still's disease. And so when we looked at these patients with a number of different cytokines and chemokines, as we go from sort of right to left, patients with inactive systemic JIA, largely normal. Active systemic JIA, we see higher levels of IL-6, but really no increase in interferon gamma or these interferon gamma-induced chemokines. However, in the setting of MAS, IL-6, TNF go up a little bit. Interferon gamma goes up a couple-fold, but these chemokines go up by orders of magnitude, particularly CXCL9, which is a chemokine that is really specifically induced by interferon gamma as opposed to other interferons, to levels that were comparable to those we can see in other sorts of secondary HLH, primarily infection-associated HLH. And then if we looked at these as sort of paired values in patients who had both an MAS episode and a systemic JIA flare, you can see that there are significantly higher levels of all of these chemokines in MAS compared to flares. These levels of CXCL9 also very strongly correlated with a number of the other laboratory features of MAS, such as the thrombocytopenia, the liver enzyme elevations, or the ferritin elevations. So suggesting first that interferon gamma is highly elevated in this condition, and second that these chemokines such as CXCL9 may be very helpful biomarkers for both recognizing and following MAS. I think Dr. Kan has spoken to some of this in his biomarker talk as part of this session. So some additional data showing this particular activation of interferon pathways in systemic JIA MAS came from a recent study from our group where we performed a large single-cell RNA sequencing profiling of peripheral blood mononuclear cells from children with Still's disease and a range of disease manifestations, including inactive disease, active disease, both new-onset disease and flares, lung disease, and patients with overt MAS. So we performed 10x single-cell RNA sequencing on this cohort and obtained a compendium over 200,000 single cells, which were then mapped to nearly 30 different specific cell populations. When we examined these different cell populations across these different clinical groups, we first looked at known interferon-induced gene modules. And what we see is that this interferon signature is most striking in patients with MAS. So if we go from left to right, up and down on the y-axis, these are all individual genes in 3 different modules of annotated interferon-stimulated genes. Across the x-axis, these are each of our cell populations in each of these clinical groups: our healthy controls, inactive systemic JIA, active systemic JIA, lung disease, and then MAS. And as you go from left to right, you see really very little interferon signature in active disease, some increase in active disease and lung disease, but really a marked and spreading interferon signature across many different myeloid and lymphoid cell populations in MAS. So looking at this another way, what we did was examine the differentially expressed genes that we see in each of these cell populations, in each of these clinical conditions compared to the controls. And we took those differential gene expression signatures and performed a correlation heat map to identify shared patterns of gene expression that are seen in multiple cell populations and in multiple of our clinical scenarios. And when we plot those together, what we see are these modules, which are sort of noted here by these green boxes. And each of these modules are groups of multiple different cell types with shared and highly correlated gene expression patterns. The largest two of those of upregulated genes are those that we see in lung disease and then here in MAS. And particularly MAS in lymphoid populations, multiple different lymphoid populations in our MAS patients. When we examine what those genes are, we see a huge network of genes. And if we zoom in on that, at the center of that is STAT1, our canonical interferon-induced transcription factor. So again, suggesting that this pathway is very highly elevated in MAS. All of this data can help us think about what are some potential treatment targets in this disease. So putting this together to think about the pathogenesis of MAS and HLH and its similarities and differences. So in a typical immune response in a healthy individual, there's an infection, such as a viral infection, which activates your cytolytic T cells. They expand, they recognize antigen being presented by antigen-presenting cells and produce interferon gamma in response to that. And then they clean up that infection. Those cells begin to contract and resolve with a role for NK cells in the contraction of that response, and we get immunological memory. In HLH, what happens is a little bit different. We get, again, some sort of an infectious trigger that leads to activation and expansion of cytolytic T cells. However, because of that cytolytic dysfunction, they're unable to kill those antigen-presenting cells. So you get this persistent production of interferon gamma, driving excessive macrophage activation. Those macrophages produce a large number of pro-inflammatory cytokines, such as the IL-1 family of cytokines, IL-6, and forming this pro-inflammatory loop. Those further activate cytolytic cells to produce more interferon gamma. Absent cytotoxicity from NK cells prevents NK cells from being able to contract that immune response, and so you get this persistent inflammation in the cytokine storm of HLH. In MAS, things are a little bit different because this trigger that starts the inflammatory response occurs in the background of this excessive inflammatory environment that we see in diseases like systemic JIA, particularly this IL-18 elevation. There can then be potentially some defective killing from hypomorphic mutations that can lead to prolonged engagement, but then production of interferon gamma, driving macrophage activation, driving further production of pro-inflammatory cytokines such as IL-18, and again, giving us this final common pathway of cytokine storm. And at the center of both of these are cytokines such as interferon gamma, such as pro-inflammatory cytokines like IL-1 and IL-18. So now let's think about how we can use some of that knowledge about the pathogenesis of the disease to think about cytokine-directed therapy in MAS. So first, let's again think about the clinical problem. Let's take another case. This is another case from my fellowship. This was a previously healthy 6-year-old boy who presented with fevers, abdominal pain, and leg pain. At the time of admission, he had a daily spiking fever for 12 days. When he was first seen in the hospital by our team, he was noted to have a polyarthritis involving his knees and his hips. He had serositis, he had a rash, he had a very elevated white count, he had a mild anemia, a platelet count, again in that low normal range, and a ferritin, that his initial ferritin being a little bit more than 3,000, but then by the time the diagnosis was made, his ferritin had increased to over 16,000. ID was consulted, a number of infectious studies were sent, no infectious cause could be found. Hematology was consulted. They had no concern for malignancy based on their examination of a blood smear. A bone marrow biopsy was not performed. Then we were consulted, and given the exclusion of some of these other causes and the classic triad of fever, rash, and arthritis, he was diagnosed with systemic JIA. Given that he was somewhat ill, he was started initially on a pulse dose of steroids. And with several days of IV pulse steroids, he began to improve. He became afebrile. The arthritis improved. His labs began improving. His ferritin dropped to 5,000. His CRP dropped. And based on that, he was then weaned to a more high-dose steroids and started on anakinra. However, with this change, he returned to having fever, spiking fever to over 40 centigrade, became tachycardic and tachypnic, had a new rash that was concerning for being a petechial rash, and worsening belly pain. And his ferritin that had been dropping went back up to over 22,000. His platelets that had begun to improve dropped again. So based on that, we increased our steroids back to the pulse doses. We increased our anakinra to 100 milligrams. We also added cyclosporin. However, despite this, his labs continued to worsen. His hemoglobin dropped. His platelets continued to drop. His ferritin continued to increase. His fibrinogen continued to drop along with his D-dimer, showing this coagulopathy. His transaminases worsened. Clinically, he continued to be febrile tachypnic, worsening diffuse pain, and now developing a petechial rash. Based on this deterioration, he was sent to our ICU. However, quickly after arriving in the ICU, he developed pericarditis with some concern for tamponade. He underwent an emergent pericardiocentesis in the unit. He was given a dose of tocilizumab, again for this uncontrolled inflammation. However, after the pericardiocentesis, he deteriorated, developed respiratory failure, hypotension with poor perfusion, and ultimately arrested and died in the unit less than 24 hours after being transferred to the ICU. So again, this case, I think, illustrates first how rapidly patients can go from sick but stable to critically ill with a cytokine storm syndrome like MAS, as well as the need for further treatments that may be more, hopefully more effective for some of these steroid refractory cases of MAS. So to think about our treatment approach, it's important to think about sort of all of the things that are potentially drivers of this cytokine storm. This is a figure from a very nice review from Alexi Gram, Anna Karen Horn, and Fabrizio De Benedetti, where they talk about the multi-layered pathogenesis of MAS. But there are a lot of things that go into this. There is potential genetic predisposition that we've talked about. There is this background inflammatory activity that we see in rheumatic diseases. There's often an infectious trigger, particularly for patients who have known Still's disease and then have an MAS flare. There's often an infection that sort of kicks things over into MAS. And then there's this hyperinflammatory loop itself with this cytokine storm with interferon gamma and other pro-inflammatory cytokines such as IL-1 family cytokines at the center of it. And each of these areas are ways we can think about potentially trying to intervene for our treatments. So the initial treatments of MAS we've kind of seen with both of those patients. It's steroids. We're rheumatologists. We love steroids. Usually for MAS, if they're in the hospital, we're using pulse dose methopred or 30 per kilo up to a gram for 3 days, 5 days. There's no science to the duration. With ultimately a plan to then move them over to a more of a typical high dose steroids. Patients with more early or mild MAS often can be managed closely if you have close outpatient follow-up with oral high dose steroids, like we saw initially with that first case. And then, for many patients, sort of that slug of steroids is enough to kind of get things under control. And then what you're able to do next and how you can wean them off really depends on what drove this MAS in the first place. If there's a known infection, when that's been treated or resolved, you largely can probably wean them off steroids. If it's a rheumatic disease, you have to control that underlying disease. And so is this a patient whose disease flared or wasn't under control in the first place? And you need to think about different background immune suppression. Sometimes it's idiopathic, particularly for newly diagnosed patients. If they don't kind of check all the boxes for this clearly being Still's disease, but they have something that looks like MAS, or it's a really unknown, we typically recommend a very slow taper with careful monitoring to see, is this a more chronic process that's going to come back as we wean steroids and need some sort of a steroid-sparing agent, or was this sort of a one-off and they're going to be able to come off steroids just fine? Other adjuvant treatments for MAS in sort of the pre-biologic environment, cyclosporin was really the steroid-sparing agent that was first shown to have some utility in MAS. It still has been used for patients who have sort of more chronic or recurrent MAS. Can be dosed IV while they're in the hospital, and then PO as an outpatient. Rituximab. So rituximab, anti-CD, CD20 monoclonal, can be very helpful in MAS or HLH that's driven by an EBV infection, particularly if those are in the B cells. Because if you deplete the B cells, you can then remove that viral reservoir and hopefully break that inflammatory loop. IVIG, I noted earlier in the points to consider paper, again, can be very effective. It's usually transient, but if you're worried about an infection potentially as a driver, again, this can be really helpful. Again, often we see patients who have Still's disease and early MAS who are initially thought to potentially have Kawasaki disease, and they get a dose of IVIG and they effervesce and they get better. Sometimes they even go home, and then as this gets out of their system, they flare up again. Etoposide, again, is part of that HLH treatment protocol. We have as a rheumatologist, I don't prescribe etoposide at all myself. I do it together with my hematology and oncology colleagues. The use of that is we call it sort of the Karolinska approach. This is what Horn and Hunter have sort of approached, which is rather than giving the high dose etoposide that's dictated by the HLH04 protocol, using a bit of a lower dose, 50 to 100 per meter squared, dosing sort of weekly to effect till you see the resolution of the disease. And this has sort of been the salvage therapy for severe MAS historically. But what about newer treatments, and particularly thinking about biologics? So cytokine-directed therapy starts with thinking about anti-IL-1 therapy. So we know that IL-1 is really a central cytokine in systemic JIA and Still's disease. Blockade with IL-1, first with anakinra, was the first biologic to be shown to be helpful in systemic JIA and has really become now a mainstay of therapy. Now, what about an MAS? So, as I said, it's clear that patients who are on anti-IL-1 therapy remain at risk for MAS. But there's increasing data that shows that high-dose anakinra can actually be very helpful in patients with systemic JIA who develop MAS. And by high dose, we mean at least sort of 5 to 10, up to 20 or even higher mg per kg per day. For me, I usually start at 10 per kilo, divided 2 to 4 times a day. For an adult-sized person, 100 every 6 hours is what I would consider high-dose anakinra. Some of the data on the safety and efficacy of this comes from an unexpected source, which is the sepsis studies. So anakinra was first used as a potential medication to treat sepsis. And so there was a large phase 3 clinical trial of anakinra for severe sepsis. These patients were given a lot of anakinra. They were given 100 mg as a loading dose, and they were put on an anakinra drip of 2 mg per kg per hour. That's a lot of anakinra. That's 48 per kilo a day. Now, the trial did not meet its primary endpoint. In fact, it was stopped early because it was not showing efficacy. But notably, there was no harm. And again, these are patients, adult patients with severe sepsis. Subsequently, there have been some reanalysis of that data where patients have been stratified for sort of these different inflammatory phenotypes, and particularly one where patients having concomitant hepatic dysfunction or DIC, which of course are clinical features of MAS. And so if you look at that subgroup of patients that have hepatobiliary dysfunction or DIC, you in fact see a statistically significant improvement in survival with anakinra in those patients compared to those who received placebo. Based on this data, a randomized controlled trial for anakinra and MAS was put forth, and I believe is still ongoing. What about IL-6? Again, another cytokine blockade that is really central to our management of Still's disease. Again, we know patients who are treated with tocilizumab remain at risk for MAS. There's much more limited literature in the use of tocilizumab for the treatment of MAS, really just case series. However, as we think broadly about cytokine storm syndromes, again, it's notable that the utility of tocilizumab for patients with CRS, or cytokine release syndrome. And this has been FDA approved based on a retrospective pooled outcome data from patients who received CAR T therapy, who then received tocilizumab to manage their cytokine release syndrome. That was based on 45 patients with a mean age of 12, with their outcome being a resolution of fever and coming off pressors. And they found that almost 70% of patients who received tocilizumab had a resolution of that CRS within 2 weeks of the first dose. So again, this potentially has utility in the treatment of cytokine storm syndromes, although less data specifically in MAS. What about IL-18, right? We talked about IL-18 again at the center of this inflammatory loop. So IL-18 has a natural binding protein called the IL-18 binding protein, which is a high affinity antagonist. This has been cloned as a recombinant human IL-18 binding protein. There was a phase 2 trial of that in refractory Still's disease patients, which was promising, good safety, and some hint of potential response. There's also some case reports of this in patients with NLRC4 gain of function MAS. We have several years ago reported the use of this medication in a patient with Still's disease and recurrent MAS. So this was at that time a 5-year-old who had refractory Still's disease, recurrent episodes of MAS and lung disease. He had tried a large number of medications, and every time we tried to wean steroids, he would flare and go into MAS. So we received compassionate use approval to use this medication, which is a subcutaneous injection every 48 hours, along with this continued IL-1 inhibition. And what we found was that this patient had a slow but steady clinical improvement, that his steroids were able to be decreased by more than 50%, and he had an increase in his linear growth rate, which you see here on the right. So again, suggesting there's potential utility for the blockade of IL-18. So what about interferon gamma? As I mentioned, interferon gamma has been known for quite some time to be really central to the pathogenesis of primary HLH. This led to the development of an anti-IL-18 monoclonal antibody called emapalumab. It was first used in a clinical trial of primary HLH. This was published in 2020 in the New England Journal. 34 patients with HLH, most of them had been previously treated, including with etoposide. And they found that 71% of these patients who received emapalumab survived through bone marrow transplant. And they compared that to the survival of patients under the prior HLH-94 and HLH-04 treatment trials, which were the etoposide and dexamethasone regimens, where they saw 51 to 59% survival. Notably, 90% of those patients receiving emapalumab who actually went to transplant survived. There were a number of severe infections, including one episode of fatal sepsis that was seen in this cohort. But given this improvement compared to the historical data, this was approved for HLH by the FDA in 2019. Based on this success, we performed a prospective open-label clinical trial of emapalumab in MAS patients secondary to systemic JAA or Still's disease. The initial trial, which was published in 2023, had 14 patients with systemic JAA or Still's disease, who all were steroid refractory. Most of them had been treated with one or more other medications for their MAS, most commonly cyclosporin or anakinra. Of these 14 patients, 93% or 13 of 14 of them reached the primary outcome, which was defined as MAS resolution by week 8, which was a combination of a clinical outcome as well as improvement in 7 pre-specified laboratory parameters. You can see in this initial group the baseline versus week 8 levels of these various biomarkers, such as ferritin, the platelet count, transaminases, the fibrinogen, and then here's our CXCL9, again, markedly elevated at the time of enrollment, and then decreasing by orders of magnitude after emapalumab treatment. Based on this, as well as the second clinical trial that is yet to be published, emapalumab was approved by the FDA just this past summer for the treatment of refractory MAS in Still's disease patients. Another important outcome from this, from the emapalumab, first emapalumab trial, was the ability to wean steroids quite rapidly in these patients. Many patients who have this severe MAS become chronically corticosteroid dependent. However, what we were able to see was a very significant, over 90% reduction in the glucocorticoid dose by the end of the trial, with most patients being on less than 0.5 mg per kg per day by the end of the trial. And then one last medication to consider in the realm of cytokine-directed therapy is JAK inhibitors. So we know JAK and STAT, right? So Janus kinase and then STAT, the signal transducer and activator of transcription signaling. These proteins mediate signals from a broad range of cytokines, including a number that are relevant to our rheumatic diseases and MAS, such as IL-6, as well as type 1 and type 2 interferons. So the JAK inhibitors, and there are several now that are on the market, are oral medications that are able to block this cytokine signaling with high affinity and broad selectivity, as you see here. So can we use these oral agents to block multiple cytokine pathways? Again, recall from our single cell data that the center of the gene expression profile that's activated in lymphocytes from MAS is STAT1. So the first data that really said that this may be a very promising approach actually came from several different animal studies. So multiple different mouse models of MAS and HLH showed that if these animals were given high-dose JAK inhibitors, specifically ruxolitinib, you could improve the clinical features of MAS. Since then, there's a number of case reports and small case series in both adult and pediatric patients with secondary HLH broadly and MAS specifically in Still's disease, showing the efficacy of, again, high-dose ruxolitinib. High dose being, so the one treatment protocol, there's actually an ongoing clinical trial of adding this to the HLH treatment regimen that's being led at St. Jude's. They use a dose of 25 mg per meter squared BID. We can use that. We also, again, for those whose math skills are more challenged to me and can't quite calculate a BSA and you go by weight, 1 per kilo per day divided, also is sort of a good rule of thumb for picking what a high dose ruxolitinib is. So an increasing body of literature supporting the helpful role for this JAK inhibitor treatment in MAS. So just to end here, I want to give one word of caution, which is that basically everything that I've just told you about MAS applies to MAS and Still's disease. And being able to translate that biological information to MAS occurring in other rheumatic diseases may not be possible. For example, if you look at the elevation of IL-18, IL-18 is dramatically elevated in systemic GIA and Still's disease and NLRC4 gain of function. However, it's not all that markedly elevated if you look at MAS occurring in other rheumatic diseases. Lupus, dermatomyositis, Kawasaki. Again, I'll note that this is total IL-18, which does not reflect free IL-18, and the differences in free IL-18 are maybe not quite as well shown. But IL-18 may not have the central role in pathogenesis in some of these other diseases the way it does in Still's disease. Additionally, whether there's a potential role for hypomorphic mutations in perforin and the cytolytic pathway in MAS occurring in other rheumatic diseases has also not been comprehensively studied. In fact, the only real comprehensive study that's examined this is in the Toronto lupus cohort, where they specifically did not find an increased rate of these hypomorphic mutations in the cytolytic pathway genes in lupus patients with MAS. So what could be happening in these other diseases? So, if we think about lupus MAS compared to Still's disease MAS, in Still's disease MAS, we see this hyperinflammatory loop that's driven by IL-18, causes a increased production of interferon gamma. In lupus, again, IL-18 is high, but not that high. But the other thing that we know that lupus has, and dermatomyositis, I would say it does as well, is type 1 interferons. So could type 1 interferons be another push that we see that helps drive this hyperinflammatory cytokine loop in lupus-related MAS that is distinct from what we see in systemic JIA? Again, very little is known about the immunopathogenesis of MAS and these other diseases. So just to be cautious. With that, I hope after this, we've successfully reviewed some of our presentation and our diagnostic approach to MAS. We've thought about some of the new data on the pathogenesis of MAS, particularly this IL-18 interferon gamma axis. And finally, using this understanding of pathogenesis, thought about some of the current data supporting cytokine-directed therapies in patients with MAS. Thank you for your attendance today. Again, great pleasure to be here, and I'm looking forward to taking some of your questions in just a few minutes. Thanks.
Thank you all for joining us for this education-packed morning. A big thanks to Dr. Grimm, Dr. Canna, and Dr. Schuler. Let's kick off this live Q&A with your burning questions. Please place them in the Q&A so our lecturers can address them live. We look forward this morning to an engaging discussion.
I have a question first to start off with, either for Dr. Canna or Dr. Schuler. Are there any specific genetic variants in the IL-18 receptor or the inflammasomes that generate IL-18 that are unique to patients with Still's disease?
So as far as I know, and I feel like I've been looking, they're not well described. There aren't even really good, strong signals of Still's having anything in the 18 locus, any 18 receptor locus, or 18 binding protein locus, specifically in Still's. IL-18 binding protein deficiency has been described in a couple patients associated with pretty bad, in fact, in a couple patients, fatal hepatitis, but not necessarily Still's. NLRC4 has an interesting association with IL-18 that goes beyond monogenic disease into some GWAS studies. They're a little obscure. But there have been a couple adult Still's patients who have been described to have somatic variants in NLRC4. And so, it is a reasonable thing to think about. We have sent kind of a deep sequencing of, maybe 50 or so Still's patients through Dr. Megan Cooper's effort and didn't really pull out any really low frequency NLRC4 variants. But the possibility is there. But I think for all of its manifestations, Still's remains sort of stubbornly not genetically mediated.
Looks like we have one question in the chat already. If type 1 interferon is important in lupus MAS, why don't we see more MAS in dermatomyositis?
So the question is, like, type 1 interferon associated with MAS. I don't know that is so true. I think that type 1 interferon is part of a lot of diseases. And I think it's one of the things that makes Still's a little bit unique. And there's a paper about to come out that has looked at interferon scores in systemic JA patients, and the stubbornly refractory patients probably do. That's from Mike Umbrella's group. But I personally think that this entity that we call MAS in lupus and in dermatomyositis is really those diseases plus usually a pretty big contribution of some other trigger. So I think, we probably do see it in dermato. It's been reported, certainly, also not associated with IL-18. But I think when you look hard in those patients, you tend to find viral reactivation or other infections. In adults, I certainly would start looking for lymphoma, but I'll let Grant pipe in.
I wonder to some degree, do we not look, similar to lupus? I feel like, the first line treatment is going to be high dose steroids, and the first line treatment for active lupus is high dose steroids, and the first line treatment for active JDM is high dose steroids. So, are we treating it without sort of realizing it? It's certainly most seen in certain JDM phenotypes, MDA5 being I think the classic example. But I think we certainly don't know. And maybe, I don't know if there's a understanding of sort of the degree of the interferon signature between lupus and JDM. Is it different in degrees or just different in flavor? I don't think it's really as well understood. But yeah, that's the caveat I always sort of say, is like everything that we just told you about MAS, we know from systemic JIA and Still's, and may or may not apply to any other rheumatic patient, with the possible exception of like the NLRC4 patients.
But I think, Randy, your point is well taken. Like, not all that has lots of type 1 interferon gives you MAS. And Ecardi Gutierrez is probably the best example, where there is no interferon signature higher than AGS. And sure, those patients in the neonatal period, they can have some thrombocytopenia, but in general, HLH MAS is not a common part of their phenotype.
We have a question from one of the participants, Maria Lopez. She asks, we usually only send CXLC9 testing for suspected HLH and hyperinflammation. Is it useful to also send an interferon gamma assay?
You mean, I don't know if you mean like a direct cytokine level or like a sort of a functional assay. Assuming you mean the level, it's fine. It's going to be elevated. Also, it's a degree of magnitude, right? It's a couple fold change as opposed to orders of magnitude change. So the dynamics of like a CXL9 is a lot easier to follow. The caveat is there's not a lot of labs that offer CXL9 and gammas on a lot of the commercially available cytokine profiles. Neopterin is another more widely available, really good gamma proxy as well.
I completely agree. I think that like CXL9 would be great. I think if we were building a cytokine panel today, it would include CXL9 and it wouldn't include IL-1 or IL-12.
Right.
But we got what we got. I think like you kind of got to know your panel, and some of the pro-inflammatory cytokine panels are more sensitive for gamma than others. How much you trust it really depends on like how often have you seen a level that makes sense in the context of a patient with HLH, and like what number are you looking for? Because that number might look really different whether you send it to Cincinnati versus whatever you're running in-house versus, Mayo's panel, whatever. So I think those ranges really are pretty different. And likewise, like even CXL9, you gotta send these things to places that are going to dilute them properly, and hopefully those places are going to get enough of these that they can increase the number of runs they do in a week so we can get them back sooner.
In that same vein, kind of thinking about hyperinflammation that's more non-specific, can you all talk about how you clinically approach, sending cytokine panels or looking at specific biomarkers as far as your like first tier testing?
Ooh, that's a loaded question. I guess I don't have a like algorithm or a heuristic. I would certainly say that like we are probably over testing, and some of that is I think justified in trying to get familiar with when are these tests useful and not useful in real clinical practice as opposed to a relatively well circumscribed like clinical study. So I think ferritin is a great screening tool. If your ferritin is not high, then you don't really need to be worried about patient being in HLH-MAS right now. So, and in most places, at least in the US, that's going to come back relatively quickly. So usually you have that in hand as you're maybe making decisions about other stuff. We have a cytokine panel that we like that we run in-house, so we send it pretty frequently. How often that actually changes management, I think, is debatable. But certainly, we use some of those patterns to try and infer kind of what direction things are going. I really like soluble IL-2 receptor as it's not quite as labile as CXL9. I feel like, you can kind of get a sense of how things have been going over the last few days, whereas, I think from one day to the next, your CXL9 can go from 300,000 down to 3,000 and then, back. So it's a bit more of a snapshot. But soluble IL-2 receptor, we use it as a poor biomarker of T cell activation. But I think that by and large bears out. And then, I think 18 we tend to send early on because it takes a little while to come back. And, depending on the level we get, it really can affect the rest of the workup that we do or don't do.
Not having an in-house cytokine panel, I can echo what Dr. Cano was saying, is we get it a lot when we're looking at somebody with an inflammatory state, thinking that it might inform our treatment later, and then we get it back like 4 days, 6 days later. And more often than not, it's like, oh, yes, there was some elevation in cytokines, but it's often the patient has already declared themselves. But then also to echo, the IL-18 is the one that we find more useful when we get it back. And it's like, yes, we can confirm to our oncology friends that this is probably Still's disease systemic JAA.
Yeah, I have a whole lot to add to that. I I don't send them very often, mainly because I don't find them super helpful. Sometimes when you're sort of fishing for some sort of a new biomarker you can use to measure response to treatment, they can be helpful. And you're like, oh, wow, the IL-6 is high. Cool, we can follow that. But usually if your IL-6 is high, your CRP is high. So, I don't send it very often.
Maybe the more you know, the less often you send them.
Can you all talk about, we talked a lot today about IL-18 and that being significantly elevated in looking at things like systemic JIA and MAS. Do you ever see this biomarker elevated in other diseases that promote hyperinflammation, such as other immune dysregulation disorders, IEIs?
I'll take that one. IL-18 is like the only thing I know anything about. And I still don't think I understand it very well. So yeah, so to go through the IEI, so NLRC4, if the patient has, a high ferritin or MAS as part of their phenotype, they're probably going to have a lot of IL-18, and it may never normalize. And when those patients are well, they tend to find their own kind of set point. And I've seen that set point anywhere from a couple thousand to, I think about 50 or 60,000 was sort of like where some patients have settled out. And it's remarkable how long those patients can go between flares with IL-18s of 20, 30, 40,000. So really, it is the kind of a cytokine that we think probably needs some other hit. There are a couple other diseases. Actually, to finish out on LRC4, the patients with a more FCAS phenotype don't always have a lot of IL-18. I think if you were to compare their IL-18 levels to a similarly FCAS-y CAPS patient, they'd be higher in the NLRC4 patient, but they're still maybe just a couple of thousand. So I don't know that a normal or not very impressive IL-18 level tells you that an NLRC4 variant is not contributing to somebody's disease, unless that is like a MAS phenotype patient, in which case I think you kind of can. XIP deficiency is likewise a mixed bag. The patients with XIP and HLH tend to have really high IL-18 levels that remain pretty high even when the patients are doing better. Those IL-18 levels get better after transplant. But there are lots of XIP deficient patients with IBD walking around who don't have much in the way of an HLH phenotype. And we've tested, a handful of those, and some of them have been, again, just a couple of thousand or even, some of them close to normal. So, it's not necessarily sort of this one-to-one correlation of the things that we, I'm more guilty than anybody of coining terms like IL-18opathies, but it's variable even within these IIs. Ultra rare things like CDC4 or CDC42, C-terminal variants, also appear to have really high 18. And then, as we send this more, I think we're going to see the chinks in the armor of the specificity. And I'm right this very moment dealing with a patient who very much appears to be EBV HLH, but her IL-18 came back at 215,000. And it's a primary EBV infection, and, she's maybe a bit more IL-1 responsive. And so, I think that we're starting to move away from this primary HLH, secondary HLH dichotomy into a more of what are the types of things that we know contribute to HLH? How can I kind of test for them and characterize them? And, I don't know that there are a ton of rules saying that you can't have things from multiple categories in certain diseases. And so if you add to that, a lot of the studies historically that have measured 18 have maybe not diluted it properly, and so they may not have been detecting in some subset of whatever they were measuring that it was really high. And so, I think that we're going to discover more. So far, I've only found one lymphoma patient who had like a really high IL-18, but sometimes in someone who has really bad malignancy-associated HLH, you'll get a value of like 20,000. And I think that is mostly like 18 production, but a lot of binding protein, and those patients tend to be very sick. So, the cutoffs, I think, just like ferritin, we use a higher cutoff for malignancy-associated HLH than we would for MAS. Your 18 cutoff is going to be different depending on like what other context you got.
I have a question regarding IL-17 and Kawasaki disease. I have not sent this off yet. Are there any commercially available labs where this testing is reliable to send to?
Should we text Pui? There are labs that will run 17. I don't know which panels it's on. I'd have to check. Does yours? The Cincinnati panel might have it. We've not used it. We've not used it clinically, but I think that I don't know. That's something that I just have eyes open for. That that seems to be at least in studies from people I know that are careful. A underappreciated association with KD. So I think Boston is running it. If they're not, they're headed that way.
I just checked one of my patients who we recently sent a Cincinnati panel on, and it does have IL-17 on it. I had a question for either you, Dr. Kanner, or Schulert. If you have a systemic JA Still's patient who presents without MAS, but they have a very high IL-18, does that change your initial management, or do you still treat them the same as you would, say, like 100,000 versus 30,000? Does it make you just more cognizant to look for complications, ILD, MAS, or do you change what you do initially?
It's a great question. For me, I don't think it necessarily changes what I do at the beginning, but it definitely sort of helps tune my level of worry for things like MAS and lung disease. Again, patients who have particularly very low, again, low for stills, right, which is in the 1,000 range, not the tens or hundreds of thousands range. I certainly have less worry about those types of complications, which that doesn't mean it can't occur. I think Scott has made the point here and elsewhere that free IL-18 and total IL-18 often don't correlate really at all, right? And so you can have a fairly high total IL-18, but not necessarily a lot of free IL-18. So I don't know if we don't have really great prospective data that says, does IL-18 at diagnosis?
I would have said that I didn't think IL-18 level at diagnosis was that prognostically useful, but I got wind of a paper very recently accepted out of the group in Rome, led by Claudio Bracaglia and Fabrizio De Benedetti and Giuseppe Principi, that they have done that, and sure enough, it does. So you're much more likely to have active disease at, I think, 12 months if you had a really high IL-18 at diagnosis. But maybe unsurprisingly, if your IL-18 was still above I forget what the cutoff was, but not crazy high level. But at 3 months, if it was still, above 10,000 or so, I think that was kind of the maybe one. Strongest predictor that this is a patient that's not going to go in a great direction. And I think that I think it was you, Grant, who said that you called it sort of a nadir that, we get a diagnosis and then, when do you check it again? It's not a very good day-to-day disease activity biomarker. So we will then send it at a arbitrary point at which we feel like, the patient really is doing pretty well. We're weaning down pretty successfully on steroids. Let's see where it's at. Because if it's 2,000, I might feel pretty good about things. If it's still 20,000, that's probably someone I'm going to worry about, even if their other biomarkers and stuff look really good. And maybe that should affect their screening for stuff like lung disease.
Yeah. I think that's exciting data. I'm looking forward to seeing that. We've looked in the Kara Frost cohort, which has it has some things that are really nice. Again, it's a nice inception cohort of systemic JAA patients. They had to meet ILR criteria. They couldn't be an overt MAS at the time of enrollment. So there's, you're sort of lopping off a couple of things. But we didn't, the baseline IL-18 didn't really associate with response. But that point about sort of how it's trend, that we did. We saw that patients who had a really good response, which we defined as being clinically inactive disease off steroids at 6 months, had a significant decrease in their IL-18, whereas those who didn't. And so, at least in that cohort, the baseline IL-18 was sort of less predictive to, does it come down really quickly? And I think the Dutch data suggesting that patients who sort of normalize their IL-18 or close to normalize their IL-18 are much more successful coming off therapy also kind of feeds into that.
I think they looked at like 2 months after diagnosis. Was that Bastard's study, like for his?
I think that's when they started checking. Yeah, and I think their sort of protocol was at 6 months. I think if they're normal at 6 months, maybe it was 3 months, that they would try to wean the anakinra, and they reported a lot of success with that. Although for me, I don't feel like I see that many patients who normalize their IL-18 by 3 months.
Yeah.
But, it's that all that good healthy living and other things that we don't make that.
Yeah. I mean, I actually want to make that point that, like, I think that, there's obviously a lot of discussion about IL-18 and Still's disease. And I think rightfully so, especially if we can start recruiting our adult colleagues to get on board. But, like, I think Still's is more than 18. I think that it's conspicuous that, NLRC4 patients don't develop lung disease to my knowledge, or that I've heard of,
and typically develop arthritis.
And they don't get, I think there's potentially overlap there, but like, I think that there's maybe something more, I don't know, pure about NLRC4 18, and those patients, honestly, much easier to manage. Even the ones that we still have on IL-18 blockade, like, they do quite well, and the Still's patients really struggle. And I think there are environmental factors that I think are beyond our comprehension, and that's a rabbit hole. And so it's entirely possible that Still's in the US is a slightly different beast than it is in Rome, and a slightly different beast than it is in Utrecht, and that affects some of those studies. But I also think that, like, we've had patients who had, pretty bad Stills, got on therapy, genuinely normalized their IL-18, and then 6 months later got some sort of infection, and everything came blossoming back in a really horrible way. And that's one of the patients that is part of Grant's transplant cohort, the Ottawa patient. That's a patient who ultimately had to go to transplant for just horrendous systemic JAA lung disease. Did really well in transplant. But I think that there's something about susceptibility to Stills that, is maybe even at a more fundamental level than what their IL-18 level is at any point in time. It probably has to do with what sort of puts them at risk of getting such a high IL-18 level. But I just think that there's still a lot more that we don't understand.
So I've actually had some patients with non-specific hyperinflammation that have not responded or have relapsed after we've weaned steroids. And we used some immune modulation such as infliximab successfully on a couple of patients. Can you guys talk about any other immune modulation that you've used that has been successful? I know we talked a little bit about ruxolitinib.
You mean sort of like for empiric, like hyperinflammatory patients that are not clearly like Still's disease, you mean?
Yeah, for instance, we had a patient who ended up having RELA deficiency, a newly described IEI, and presented with a hyperinflammatory syndrome. Her IL-18 was over 200,000. So we treated her as MAS. She ended up doing pretty okay. Her ferritin got down to about 15,000. And then as soon as we weaned the steroids, it started going up again. So there had been some successful data using infliximab, and we tried that, and she did well. So, whether or not this was the RELA deficiency driving the MAS, or if it was like an interferonopathy, I just wonder if there's these non-diagnosed immune dysregulations that are driving the MAS, and if we should be looking to target, other parts of the immune system.
Yeah, I mean, I think the short answer is yes, right? I mean, I often, again, it is often sort of a guess and check. We try something that we have good familiarity with and sort of see if it helps. Again, sort of immune testing, both on a research and a clinical basis, can sort of sometimes help guide those decisions. Does this feel something more auto-inflammatory? Where you would say, well, let's try IL-1 or IL-6. Versus maybe trying something that's more, TNF driven. And kind of sometimes it's good medicine. And that's why we use it for like these really recalcitrant uveitis patients. It just gets into tissue really, really well. So, I mean, yeah, I think we all have sort of these patients where we can't really put a name on it. The genetics is normal, but they're sick and they seem to do better. But honestly, it's often sort of cycling medicines to finding something that's going to help them the most.
Agreed.
Scott, anything more profound than that?
No, I mean, it's trial and error.
Yeah,
Although I like guess and check. That's a little more reassuring. That's a much better phrase. But
I like guess and check.
I think we also really struggle, right? Like most of our Stills patients are not going to have a monogenic cause. But the more you sequence, the more you're going to find people that have funny variants. And that's in no way to cast aspersions on the pathogenicity of your REL-A patient, but just to say, like, it's a lot of work to ascribe pathogenicity to a VUS, even if it's in an immune gene, and even if you have a crazy high biomarker. And so I think it is really like reading the tea leaves, and I think it's one of the things that's going to keep rheumatology relevant. Is that I don't know that there's a lot of other specialties that are maybe taking it on with the hopefully the gusto that that the rheumatologists are to know what the right tea leaves to look at are and what how to interpret them in light of each other. And it hopefully someday will be. This is exactly the kind of thing that machine learning is really good at. And maybe we'll get there someday. I think the challenge there is going to be, the inputs have to be comparable. And if we're all sending slightly different tests at slightly different times with slightly different readouts, accommodating that within some sort of LLM is going to be a challenge. But, I think that, we draw these arbitrary axes of inflammation, interferon alpha, beta, interferon gamma, more classical autoinflammatory type. And then, we ascribe things that work for those. And sometimes the genetics are helpful. And so, yeah, if you're looking at like a NF-kappa B pathway disease, I think empirically a TNF inhibitor makes a lot of sense. But sometimes, it doesn't, right? Like, so RIPK1, CREA, those patients respond to IL-6 inhibition. Why? I don't know. Maybe somebody knows, but the reality is that they do. And it's our sort of responsibility to try to chip away at the edges, whether it's the genetics or the response to treatment, to try to understand, how we get there, right? Like ADA2 deficiency, also, really TNF responsive. Why should that be?
Question from Dr. Ebens. For each speaker, what are you most excited, passionate about in testing/technology for providing the best care for your patients, and what's on the horizon?
I'm pretty excited by the biomarkers that we've got, and would just love to have more availability and shorter turnaround times. I don't know that there's not like, oh, I really wish that we could send for this one thing. We're very lucky in the US that there's enough lab developed tests, and at least for now, the wolves are not trying to tear those down. That we can send these things out, and I think we're still trying to learn how to use them. I'm a little maybe disappointed in, I think maybe 5 years ago, I was pretty hopeful that some of these serum plasma proteomics things were going to tell us which are the best and how to use them. and so far not quite yet.
Yeah, I think we're at an interesting place right now because we have so much data, and we're sort of having all these new ways to think about sort of integrating and analyzing it with with AI. But how can we use that in a way that's actually going to sort of generate new hypotheses or sort of better ways to approach these patients and not just sort of give us sort of AI mirages? So I think similarly from the genetic standpoint, it's becoming a lot easier to get genetic testing on these patients, which is great. But then we get a lot of, the VUS problem is just becoming even bigger, right? And so we get, if I like some of the commercial tests as well as our in-house testing that we send, I like because they report a lot of VUSs, but that's also the downside, right? And how much do we attribute to that VUS? They said sort of the functional testing to really sort of quote unquote prove that it has a positive role is generally more than you can do for a single patient. But on the other hand, then you say, well, every patient with this variant acts in a certain way and should be treated with this way, is also probably not the case. A lot of the commercial whole exome whole genome sequencing, you send them and it comes back and they say, oh, the residents say, oh, it came back negative. I'm like, well, what does that really mean, right? We know that they found literally tens of thousands of variants, right? Including probably some variant that's never been seen before in any human who's ever been sequenced. But their algorithm has decided that none of that matters. And probably some of it did matter. Did it matter in an actionable way that would impact how we treat this patient? Maybe or maybe not. But I think figuring out how we report those variants and how we consider them and how they impact how we approach the patient is something that I think about a lot, particularly in these sort of undefined autoinflammatory patients. And hopefully, again, I think that's also sort of a way where some of our new machine learning and AI tools can help us think about all of that data that we get, and combining it with all the data that everyone else is getting. But of course, to do that, we have to find ways that we can sort of share that sort of annotated clinical genetics data, which is not something that is very easy to do and been very successful at doing out across institutions. And I think efforts, consortiums, including this, including TARN, including others, hopefully will facilitate that.
As the true non-expert in this group, I say the thing that's exciting to me the most is the collaborative nature, I'll just say, of immune dysregulation, since this series here kind of highlights it's not just rheumatology, but immune dysregulation across the board of people who are wanting to come together to talk about these difficult topics, and the ease of access for a junior faculty like myself to reach out to the experts to get their help. I think that to me is the most exciting in the field, and I use it quite frequently.
I will say, like, I'm increasingly excited about the quality of some of our resources, and I think this is where it's great to have a listserv, but it's better to have a real resource. Lately, for variants, I've been pretty impressed with QIAGEN's like Franklin tool thing. It just has all of the right information kind of all in the same spot, and you can toss in your variant and get connected to lots of places. I don't pay a ton of attention to their pathogenicity predictions, but they're there for you, and so you can see Revel and CAD and alpha missense and population frequencies, and so like that has really streamlined the process of, oh, I have a VUS. How do I figure out what everybody knows about this? Has made that much quicker, and I think I hope to see more of that. I think like in fevers has great potential and has made some iterative steps, like the addition of some of these variant screen results attached to variants within resources like in fevers. So like Seth Masters' group did a NLRP3 functional screen, and like the assessments that they did are attached to the variants within fevers. And I think that like as more of these variant screens come out for other genes, hopefully they'll get attached to, not everything's going to be in fevers. It's going to be things in, hopefully ClinGen will kind of like collect all of this. But I think at least for genetics, that kind of ability for clinicians to on the fly have a resource that is curated and that kind of brings all of the available knowledge in a way that you can get to it and use it without, having to block an entire afternoon. I think we can get there. And AI has helped as well. Like, you get a report back that says, oh, they have a deletion from this point to this point on chromosome 3. And I used to have to go in and, map that out and see what genes are in there. And now you can just ask, open evidence or whatever your favorite AI thing is, what genes are in this region, and you get it back in 45 seconds. And, that's been pretty helpful. So genetics, again, are kind of leading the way, but, more of those resources, I think, are going to be coming online, and hopefully including more and more patient data.
Thank you for all of those comments. We have another question to discuss the therapeutic approach for systemic JIA and lung disease.
All right, so I guess that's for me. I'm increasingly reaching the point where this disease, where it's like what one of my mentors told me about lupus, which is you've seen one patient with lupus and you've seen one patient with lupus, that there's a lot of heterogeneity in patients who have systemic JIA and develop lung disease. There's certainly sort of this most common phenotype, right, which is someone with very early onset systemic GIA under 2, little to no arthritis at the beginning, very high IL-18s, moldering MAS, kind of never gets fully controlled with IL-1, IL-6 blockers, and ultimately just sort of have clubbing or something, and then has CT findings of sort of interstitial thickening, some pleural thickening, very bronchivascular thickening. And if you do biopsy them, see some amount of pulmonary alveolar prognosis or endogenous liquid in the back there. I feel like I'm seeing just as many patients who sort of don't clip all of those boxes recently, particularly as we're starting to image these patients sort of more and more early. I think we're finding that that is maybe just the tip of the iceberg, and there's sort of more early disease, but there's also sort of more atypical lung disease that doesn't sort of fully fit that pattern. So my broad approach is ultimately you need to control the underlying systemic JIA inflammation. The patients who we've seen who've done really well long term, disease was able to kind of get under control and sort of reach a more either a steroid-free or a very low steroid remission of their systemic JIA features. I like JAK inhibitors. I like things that target T cells like tacro or cyclosporin or MMF. As far as anti-cytokine blockers, if it feels like, I think the family and the primary docs have a pretty good feeling of whether it's helping or not. If it's not helping, I think you should stop it and try something else. If it's helping, then I think we'll sort of add some things to try to get the inflammation under control, cool down those T cells that we know are in the lungs, and see how we do with that. I've not had the black and white experience that's been published that if you stop anti-IL-1 or IL-6 blockers, the lung disease invariably improves. I've certainly seen some of those patients. I've also seen patients who you stop it and the lung disease doesn't improve. I've also seen patients where you continue it and you add a T cell blocker and the lung disease does improve. And I've seen a lot of patients where you try everything and nothing else. So this is where I say that there's not sort of the one size fits all of just stop the inhibitors, start a JAK inhibitor, and pat yourself in the back and declare victory. That's not been my experience. What I think we are in now is at what point, do we think something like bone marrow transplant is going to be the best option for a patient? And that's kind of a moving target, particularly as new medications are coming onto the scene. There is, again, increasingly published case reports of MAS 825, which seems like for many, but certainly not all patients in this phenotype, can be quite helpful. And as that, ultimately is in clinical trials and hopefully on the market for something eventually, I think becomes part of the armamentarium. But I think the biggest thing is sort of aggressively trying to control the inflammation, stopping antistatic inhibitors if they're ineffective or if there's concern for hypersensitivity, and watching closely for lung disease that's progressively worsening. Because certainly progressively worsening lung disease, despite all of these things, is, I think, for me, a clear indication to go towards bone marrow transplant, given what we know in our armamentarium right now. That's maybe the Cliff Notes version.
Whatever I know about this, I learned from Grant. So we try to do that. And totally echo, like, I think, if there's a gestalt lately, it's kind of like, I think that maybe we're not being as aggressive early as we should be or should have been. If we have a patient, they look pretty well, their IL-18 is still high. Oh, that CT doesn't look great. I think that we have tinkered when we maybe should have, blasted, and that is probably colored by some recall bias of the patients that don't do well. But there are plenty of those, and I think it gets really hard to treat these patients once disease is really socked in. I've no data for this, but it just feels like there's some kind of epigenetic, socking in that it just becomes very hard to capture patients once they have been, smoldering, if you want to use that term, for some length of time. I think that, like, this systemic GI lung disease is just an absolutely agonizing example of, like, the best time to transplant is always 5 years ago. And all of us have these patients that we see who, we've been more aggressive. We think we've captured their disease, but things not all the way better. If we knew that patient needed transplant, that's the time to transplant. But even under those circumstances, you might have taken your risk down from 30% mortality to 10%. But, like, it's 10% mortality of a kid whose CRP and ferritin and CBC are normal on, canakinumab and some tacro or some rux or whatever. And you're kind of just waiting to see what happens through this respiratory season. And I don't think that we have great lung biomarkers. I think, Grant's doing great work working on that. I think that we don't have a good sense of how the progression of respiratory symptoms and CT findings might trail beyond when the inciting damage is. And so, making decisions based on changes in radiology. Yes, Randy, that's the one that that because of Grant's work, we've started looking more and more at as well. If you make a big pivot based on a CT change, that might reflect something that happened months ago. And so, yeah, I don't know that any of us have a better thing to say than, like, we just do the best we can with what we have. There is a really crazy amount of heterogeneity. Not every patient has been biopsied, so the biopsy patterns that are out there may not be totally comprehensive. It's a wild west out there, and maybe we'll figure it out. But in the meantime, there's a lot of work to be done.
I think there's some interest from the community in thinking about, can we come up with sort of consensus treatment plans for refractory disease? So at least, I don't know, one of the things I learned, I don't know a lot about quality improvement, but one of the first things I learned that really struck me is that it's better to do things the same than to do it right. And I think we as a field do that kind of poorly, right? Because we want to do it right, obviously. But in some ways, it's easier to try to do it the same and then figure out what is and isn't right. That was the success of the early clinical trials, JIA. Everybody was doing everything differently, and finally, the historical potpourri, right? The first successful clinical trial of any medicine in juvenile arthritis was methotrexate, And it was done through collaboration with the Soviets, because they would just tell their people what to do and they would do it, or they would send them to Siberia, right? It was nice and easy. So it was very easy to come up with a consensus when you're in an authoritarian state. But that worked, right? Because they picked one dose of one drug and they showed it worked. And that, when everybody is doing 25 different things, it's really difficult to figure out what's working and what's not. But of course, getting everybody to agree on what to do is a challenge, because we, especially when we're flying in a data-free zone, where you can't fall back on the data of saying, well, we know this works. So we try to then, through retrospectively trying to look. Already notes we are becoming an authoritarian state. So glass half full. Maybe we are becoming an authoritarian state. Then we try to use the retrospectoscope and say, okay, well, these patients seem to do well. What were the shared features of those patients that we didn't do? And can we then replicate that in a prospective way? Things we're trying to do within the care registry is sort of follow these patients over time, understand their disease trajectories, and then try to make associations between how they were managed and patients who had good or bad disease trajectories. But that's hard, especially for a simple basic scientist like me. Patients are complicated. Mice are easy. Scott will tell you, mice are easy. Patients are complicated.
I do everything the hard way, so nothing is easy. But yeah, they don't follow rules, and yeah, I think that's a really good point. Like, it's better to do things the same. And COG is probably like the example that everybody shows. That, like, if you had leukemia, you were getting on a trial, period. And it's easy for us to say that because we're not the parent making the decision about whether to enter that trial or not, and knowing, like, if that was a step forward or a step back. But the alternative, I think we're learning, is AI is not going to save us. A lot of these drug repurposing algorithms, practically any disease you put in there, it says block TNF. So I think that there are some innovative ideas about how to do, higher throughput, but still prospective clinical trials in rare diseases that don't have the kind of momentum behind them that they would need to actually be successful. So I think, like, it's exciting that those ideas are there, and maybe with time, they'll actually be the infrastructure to sort of build them. But there are some upfront costs that I think are necessary to, like, being able to do this.
To the point of the biomarkers for ILD and Andrea's comment, so KL6, there's a lot of data on that in adult ILD and CTD ILD. It's for both a diagnostic and prognostic biomarker. Eileen Reif, who is a new faculty at UAB, has been working with us, and it seems to perform quite well in systemics, and it's clinically available through one of the commercial labs. I can never remember which one.
It's ARUP.
ARUP. I was going to say it's easily Googleable, but it seems to be quite good. So Eileen presented some of that work at ACR and is currently writing that up.
But I mean, not to, this is a biomarker talk, and so it's worth pointing out, like, Grant's being modest, not all KL6 is the same. And so, I think that I only know it's the ARUP one because, we listened to you when you said, yeah, they use the right kit.
Yeah.
But if you don't use the right kit, you get the wrong answer.
Yeah, we spent a lot of time, I mean, not a lot of time, but several months, we burned through a couple different commercially available research level kits, it was like a random number generator. Like, seriously, like, we would run the same sample again and get a value that's like 5 times higher. And well, this is crap. And finally, through a lot of literature deep diving, we're like, this is the one kit that works.
And it is so easy to, we think, oh, I'm just sending off an IL-18 level, but the way that it's run in Mayo, they don't report out values above like 12,000 or something, and have not been responsive to people saying,
makes
like,
a difference.
That is not a helpful test for anyone. It's taken a lot of work to get one of the more responsive commercial biomarker testers to get to do it, the right dilutions. And even if you want to be doing the right dilutions, I think that the paper that again, Grant kind of led this international speaking the same language effort. A group in Munster had a very well-built Luminex multi-cytokine panel with very careful dilution parameters and still got it wrong. Because the cutoff at which they thought they needed to start diluting things was actually much higher than what they should have been using, because it was based on a standard curve and not dilutions of patient samples. And so some of that knowledge probably of sort of biomarker optimization for things that are crazy high is kind of trickling out, and we're going to get better at it. But it's still sort of caveat emptor. It's still, you got to know what, you can't just send this test that has the right name, because unfortunately it may not be the right kit or it may not be the right process.
Question in the chat about HLH triggered by flu in a child with ALL. That seems like a bad Venn diagram.
Yeah.
Yeah.
I mean, there's some very preliminary data suggesting that, treating the HLH part of malignancy-associated HLH is worth it. There's a retrospective study showing that etoposide, as part of those treatment protocols, the patients do a little better. And there's some stuff starting up looking at Gamifant in malignancy-associated HLH. So I think we'll be learning more about that. But, my take on infection-associated HLH is always like, you've got a clear pathogen.
Yeah.
It's just, you can temporize all you want, but, we've dealt with patients with chronic fungal infections or, CMV that was just constantly reactivating. And there's just no substitute, because, what it takes to shut down the T cell response enough that it's not going to get revved back up by an infection is just going to give them another infection.
Yeah, agreed. It's really a Goldilocks thing with immune suppression, right? You want your immune system to work. Anything you can do to treat the infection directly, whether it's, viral specific T cells, any specific antimicrobial agents, rituximab, if you've got EBV hiding in your B cells, is going to be helpful with, but yeah, you certainly worry about, taking like etoposide in somebody who's infected. Anakinra, again, high-dose anakinra is often sort of in that Goldilocks zone, right? Because we know from the sepsis data that it was at least safe at very high dosages in adults with severe sepsis. Effectiveness, mileage may vary, but it's something that I like to reach for in those sicker infected patients.
Yeah. But maybe if you look at EB, I don't consider myself an EBV HLH expert, but I think it's an exciting time where the immunologists, in the absence of any EBV antiviral, the immunologists, I think, have really pushed and made some really startling inroads, such that our infectious disease colleagues might actually need to start paying attention to immunology more, because, okay, you've got EBV. Maybe you want to B cell deplete. Sometimes that'll work, sometimes it won't. Maybe you want to give a PD-1 antagonist. And that, the data for that are pretty staggering. That, so these targeted ways of tweaking immune responses in ways that preferentially help the clearance of a specific pathogen, I think is like a undiscovered country right now that, if phage doesn't fix all of our antibiotic problems, then knowing more about the immunobiology of the bug in a way that we can now tweak the host response to do a better job, I think holds a lot of promise for some of these more complex infections. And EBV HLH, I think, is maybe leading the way there.
I think that wraps up our talk today. I think everyone would agree we had 3 wonderful, amazing talks and a great discussion. So big thanks for everyone for joining today. A huge thanks for Dr. Canna, Grimm, and Schuler for taking time out of your busy schedule and to share your expertise with us. So thanks again.
Thanks, Joe. This was fun. Great questions.
Thanks for having us.
Good to see everybody.
Thanks, everyone. Have a good day. Have a good holiday, everybody.